Thank you so much, sir. Now heading on towards the second session, topic for which is arterial imaging and role of radiologist in workup of peripheral arterial disease. It's my immense pleasure to welcome the chairpersons for this session, Brigadier Dr. C.M. Verma, sir, Senior Consultant Radiologist, Dr. Rajendra Bhojwani, sir, Senior Consultant Radiologist, and Dr. Akshara Gupta, ma'am, Professor and Head of the Department of Radiodiagnosis, GRMC Gwalior. Please, ma'am, please, sir, kindly take your seats. This session will be divided into 3 lectures. I would take this opportunity to request our next speaker, Dr. Rajesh Baghel, sir, to please come upon the stage and share his experience on the topic with us. And I would also request our respected chairpersons to please introduce sir to us.
First of all, I want to thank the organization committee for inviting us for this. And now next speaker is Dr. Rajesh Baghel, who happens to be from my college. And he has done his MD diagnosis from Netaji Subhash Bose Medical College and currently working as associate professor at Department of Radiology. He is with many years of experience and expertise in the field of interventional radiology. He is a pioneer of peripheral angiography and USB guided intervention in the GRMC. He has worked extremely in the field of Doppler and angiographic evaluation of the peripheral arterial disease. I request him to go ahead.
Good morning, everybody. My talk on arterial Doppler study of lower limb, especially focused on intervention. What should be reported in report of radiologists, which can help intervention radiologists and the fellow surgeons to do kind work. So let's start. Anatomy of lower limb arteries, Doppler waveform of lower limb arteries, and causes of lower limb arterial disease. These are the main points on which we will talk. So first, anatomy of femoral and popliteal arteries, which are the main arteries and which are evaluated with Doppler. So normally the caliber of the common femoral artery is 4 to 6 centimeters and 6 mm in caliber. It's divided into superficial femoral and then popliteal artery. Next, lower limb is below knee arteries. This is important intervention point because most of the time stenting and other procedures are difficult in below knee arteries. They are divided into anterior tibial arteries and the posterior tibial arteries and its branches. The normal diameter of the lower limb arteries as 21 to 24 mm in diameter aorta. So the evaluation of the lower limb Doppler should be started from infrarenal aorta, then bifurcation, then common iliac arteries. It should not be started from the common femoral arteries because many of the lesions are in common iliac arteries and at the bifurcation of the aorta. So evaluation is from aorta itself. Now we will start evaluation. That first we evaluate the arteries with the B scan. aortic valve, which is a forward flow. So this is systolic and diastolic and so on. These are the mathematical formulas by which we determine some quantitative values. How much flow is there? So these are the quantitative values which are determined by the spectral waveform. So this is the slide showing triphasic flow, high forward systolic flow, and then downtick due to arterial, and third one is due to aortic valve closure. This is biphasic flow showing only two waves. One is upstroke and another one is downstroke. This is usually seen in arterial vasoconstrictions and acute arterial obstruction distal to the sampling portion. Then this is monophasic flow. Only one side of the baseline there is flow with sharp upstick but minimal diastolic pressure or diastolic flow. But diastolic flow can increase in cases of when patient having exercise, fever, or some distal infection, or some temporary arterial occlusion, which dilates the vessel and increase the diastolic flow. When the distal flow is severely stenosed arteries, it is power status. Means there is very little upstroke in systolic wave and high diastolic flow. As this is seen, the normal upstroke and followed by raised diastolic flow in lower slug. So causes of arterial disease, there are many causes. Atherosclerotic is the commonest cause, then the thrombosis, embolism, aneurysm, intimal dissection, pseudoaneurysm, AV fistulas, arthritis, entrapment syndrome, and cystic adventitia diseases. These are some of the causes which affects the artery. This is the classification for surgeons, and it should be also known to radiologists to how to classify them so that they can help their fellow surgeons. This is line diagram to show how to take the sampling and where to take the sampling. So it is pre-stenotic area where triphasic waveform is there, and at the site of the stenosis where the systolic spike is there due to stenosis. The spike is always seen when the symptomatic stenosis is there. That is more than 60% stenosis, then the systolic velocity increases. And third one is distal to the stenosis, which showing parva status flow if stenosis is severe. So this is showing the grading of the lower limb artery stenosis flow pattern. That is monophasic flow with high systolic and high diastolic flow. And lower slide showing severe stenosis, which is dampening the systolic peak, and the flow is known as parva status flow. So lower limb artery stenosis, we should start as, from the lower aorta, that is infrarenal aorta, to see the bifurcation, then the common iliacs, then common femoral, and subsequent branches. So most of the diseases in atherosclerotic plaques is seen in these areas only. Infrapopliteal or below the artery showing other diseases rather than the atherosclerotic plaques. That is in India, Buerger's disease is the commonest thing. So stenosis. So stenosis 30 to 50%. Normally they are asymptomatic or having some mild symptoms. When the stenosis is 50 to 75, there is some stenosis. Some symptoms may arise due to exercise or some physical exertion, they are exposed. And when the 75% or more stenosis is there, the PSP also increases and symptoms also increases. So these are the values which we should look for to report stenosis.
or impact of stenosis. The thrombosis is the second causes, and these affects usually smaller arteries, but they also affect larger arteries if thrombus is big. Then the thrombus age is very important as far as treatment is concerned. If thrombus is hypoechoic or hyperechoic, then it is considered that the thrombus is acute in nature, and we can have some conservative measures like thrombolysis. If thrombus is chronic in nature, then the caliber of the artery becomes smaller than the previous segment, and thrombus become hyperechoic, where the normal thrombolytic therapies and they fails. So we should think of and refer patient for some other measures like angioplasty, stenting, and newer methods like laser angioplasty and atherectomy devices such as rotablations. So classification of the thrombus, usually they are origin from cardiac, arterial, venous thrombus, and so on. So we are not going in there. The location of the thrombus is very important within the vessel. Whether they are on the one side where the possibility of doing some intervention is good and results are excellent. When the thrombus is occluding whole of the circumference, then it is difficult sometimes in a chronic thrombus to navigate through that obstruction. Saddle thrombus at the bifurcation, where we have to manage two ways, the proximal one and the branches as well. Then the canalized thrombus, this is usually a chronic type of thrombus where some lumen is recreated within the thrombus due to various therapies. So this is important to characterize the thrombus according to the age and according to the site. And this is the color of the thrombus. If it is hyperechoic and hypoechoic, it is considered as an acute thrombus where we can have some conservative measures. But as the time passes, that is beyond the first week, the thrombus is quite hard, and it is very difficult to manage it with thrombolysis. So we think of some alternative procedures. Then third D is the short segment involvement and the long segment involvement. The short segment involvement having very good results when you are going for some interventions. Long segment usually have very dubious results because occlusion rate is very high. It is around 30% in a 1 year they may get occlude, and patient come to you again and again. So whenever you are dealing with this involvement, you should have to communicate with the patient well that this is a short segment, excellent results, and this segment having long segment involvement, that results might not be that good. So arterial thrombus, they grow retrogradely, and they frequently occlusive as the time passes. So this is the duration. Basically, on the duration, we report if up to 2 weeks we consider thrombus as an acute, 2 to 6 weeks we consider as a subacute thrombus, and beyond 6 months we consider thrombus as a chronic thrombus. And again, the echogenicity, low echogenicity in the acute thrombus. Sometimes it may be hyperechoic. When it is hyperechoic, hyperacute thrombus, it may be hyperechoic. That is bright in color. And how we can differentiate between the hyperechoic thrombus, whether it is acute or a chronic one, that we see the lumen of the artery. If it decreases, then it is a chronic one. If it is expanded from the proximal one, it is usually acute thrombus. So echogenicity is somehow dubious when we are reporting the age of the thrombus. Again, then the flow, these all are complete thrombus or asymmetric thrombus, and in a later stage there is collateral formation, which good, and So this is a slide showing color flow and atherosclerotic plaques and thrombus filling in it. It is hypoacute thrombus, so it should be acute thrombus. We should take this patient for thrombolysis. This is treatment of arterial thrombus. Thrombolytic agents, embolectomy, balloangioplasty, stenting, and the bypass graft. These all depend on the age of the thrombus and the length of the thrombus it is involving. So again, second is plaques. Plaques may be hard and stable plaque. Usually calcified plaques are hard and stable. Soft plaques are usually cholesterol plaques. They are very notorious. They embolize, they ulcerate, and cause complete obliteration of the distal vessels. So it is also important to report the nature of the plaque, whether it is hard or a soft plaque. And again, if it is a hard plaque, then we should think of newer therapies like laser ablation and rotablation, because they are very difficult to do angioplasty and stenting. So, and third disease is aneurysm. Aneurysm is diameter increases 50% of the normal expected diameter. If it is less than 50%, it is known as ectasia. So aneurysm is of two types. It is false aneurysm and true aneurysm. True aneurysm where all the walls are dilated, and false aneurysm is where there is breach in the one of the vessel wall and there is protrusion. They usually false aneurysm are eccentric in nature, and true aneurysm are circumstantial. So, and third one is dissection of the aneurysm. There is a flap-like structure which are floating between the lumen, and there are two creating two lumens. These are the common sites for the aneurysm: infrarenal aorta, common iliac arteries, common femoral arteries, and the popliteal arteries. Common femoral artery aneurysm are usually heterogenic or maybe due to trauma. And infrarenal aorta aneurysm usually atherosclerotic in nature. This is the popliteal artery images showing flow and aneurysm. Popliteal artery aneurysm is the commonest due to trauma. There is complete thrombosis of the popliteal artery. These are the pseudoaneurysm where the flow is zigzag. Pseudoaneurysm of the common femoral artery showing zigzag flow. Intimal dissection of the abdominal aorta is also cause for lower limb ischemia, but it is very difficult to identify in obese and every patient. So we should go for such patient CT angiography. That is better investigation for determining dissection. This is images showing the fistula. What happens is when there is fistula between the arteries and the vena, there is increased flow. That is increased diastolic component in the arteries. Next is disease which affect the artery is arthritis, very common in Indian setup. That is thromboangiitis obliterans, that is buzzer disease, which is the commonest cause of arterial disease in India. Especially it affects the lower limb, below knee arteries, where any intervention is very difficult. So these are the flow patterns showing the wall thickening, where remnant lumen showing spiral corpus to flow in it. Then it is 100% diagnostic that the patient is suffering from the Burz's disease. These are the various waveform color flow within the vessel of the Burz's patient. And how to report. The most important thing is how to report, how to convey your findings to your fellow radiologists and surgeons. So we should do it in diagrammatic representation. That will convey your message well. So every segment should be evaluated, length should be given, so that whether it is a long segment or the short segment, usually short segment has very good results, so that we can communicate our strategy to the patient well. whether the segment involvement is short or long segment. Secondly, the plaque, whether plaques are hard and soft plaque, that is very important as far as further evaluation is concerned or further treatment is concerned. Then below knee arteries and the above knee arteries, that is also important as far as treatment is concerned. So, with this, I am finishing my talk. Thank you.
Thank you, Dr. Bagel. Any questions or queries from the student side? Especially you want to clarify?
Thank you, Ravi. Thank you, sir, for such an engaging and informative talk. I would now request our respected chairpersons to please felicitate Associate Professor Dr. Rajesh Baghel, sir, with a memento. Please, sir, please, ma'am. Moving on to the second lecture, I feel extremely humbled to welcome Dr. Aman Kumar sir on stage to enlighten us with his talk on advanced management in peripheral arterial disease patients. Please sir, I would also request our respected chairpersons to please introduce us to Dr. Aman Kumar sir.
Dr. Aman primarily trained in endovascular and intervention radiology from Tata Memorial Hospital and currently working at in charge intervention radiology services in AIIMS, Bhopal. He has international accreditation in the field of intervention radiology and publication in peer-reviewed journals. He is a national speaker in Indian Radiological and Imaging Association and the Indian Society of Vascular and Intervention Radiology. His area of interest are peripheral vascular diseases and acute stroke interventions. Please, Dr.
Thank you, sir, so much for a lovely introduction. Good morning to all the respected seniors, dear friends and colleagues. I am thankful to Akshara ma'am and Dr. Manohar for inviting me here for a much needed CME in this region. So this presentation may sound a bit of a repetition of the first lecture by Dr. Rajesh, which was excellent and had covered almost everything in one presentation. So let us be positive and think it to be a revision rather than a repetition. That would be better. And let's start with, so basically there is a slight modification in the presentation. I am going to present a diagnostic approach because advanced imaging, yes, we will discuss at the end the CT, MR and utility of these imaging modalities, but it is important to know at what stage, what imaging we need and what is the purpose of the imaging. So why do we need imaging at all in peripheral arterial disease? So the purpose of imaging is to diagnose the peripheral arterial disease. Now why do we need imaging for diagnosis? Because there could be heterogeneity in the presentation of the PAD. The typical symptom which we take in excluding peripheral arterial disease is intermittent claudication, which is seen only 30 to 40% of the patients having underlying peripheral arterial disease, and there is a whole spectrum of non-specific symptoms. Patient may be harboring a severe peripheral arterial disease and may not have that symptom. So for diagnosis of peripheral arterial disease and to assess the severity of the underlying PAD, which more often is done on the clinical grounds, but it can be corroborated with the measurement of the physiological tests and imaging. Imaging will guide us whether we need a conservative line of management or we have to intervene and do some kind of revascularization therapy. Imaging also needed to look whether it is a single level disease or a multi-level disease, which will again guide the type of revascularization we are going to attempt. Location of the lesion. This is a very important role of imaging in locating the lesion. Suppose you know there is a decrease in the peripheral pulses, but where is the lesion? Is it aortic, aortoiliac? Because all of these different territories behave differently to different revascularization therapies. To decide on the surgical or the endovascular management, to monitor therapy and for surveillance of the intervention or any therapy. So what are the armamentarium we have in diagnosing and evaluating the patients with peripheral arterial disease? Ankle brachial practice has been already discussed in the first talk. We'll just again touch upon that. Toe brachial index. Now all these 4 imaging, these are not the part of the radiology but very, very important investigations. They tell us about the physiology and the functional function of the circulation in the limb. And the next 4 are the morphological assessment which are specifically needed when we are planning some kind of intervention. We don't have to do CT, MR, angio in all the patients of the peripheral arterial disease. Only patients whom we are planning some kind of re-intervention, we have to do these imaging modalities. So ABI already discussed in the, it's a very simple procedure, doesn't need a very just need a handheld Doppler and a sphygmomanometer. We have to take the ATA, PTA. So usually we do both the PTA and the DPA, ABPI, not only one, because that is, if you want to do a screening, you can use the one. Because patient may be harboring a disease in the anterior tibial artery and that will be missed if you do only a PTA ABI. So you have to do both the arteries to rule out the severe disease. So higher of the brachial divided by the systolic pressure of the ankle will give you a ABI. So what will you do? Once you have taken an ABI, ABI will allow us to categorize the severity of the disease. 0.9 to 0.4 is considered to be normal. The lower the ABI, the more severe is the disease. Now, what to do when the ABI is more than 1.4? So that is suggestive of the arteries which are not able to be compressed, or the calcified arteries, which is commonly seen in patients with diabetes and chronic kidney disease patient because they have medial arterial calcinosis. So the interpretation of the ABI, if it is less than 0.9, I think this is a typical error here. 0.9, you know you are dealing with a peripheral arterial disease, patient is a symptom, you know it is a vascular cause, nothing else. You have to make sure. If it is 0.1 to 0.4, but still, now it appears to be, it is a normal ABI, but if the patient has a symptom consistent with the vascular disease, then you may have to do a exercise EBI to unmask the underlying lesion. If that comes to be a normal, then you have excluded the vascular cause of the patient's symptoms. Now, if the ABI is more than 1.4, that is, if the patient has a diabetes or CKD, you have to do some kind of other imaging modality to rule out the peripheral vascular disease, because 1.5 is, as I treated, this could be seen in medial arterial calcinosis. So you can do what is called as the TBI, which is again a form of the physiological test, where you use a photoplethysmograph and a toe cuff to measure the systolic pressure in the toe divided by the brachial pressure. So now we'll in this talk and the next talk we'll be hearing about the task 2 recommendations and also transatlantic intersocietal consensus is basically an international consensus which guides us about the treatment and evaluation of the patients with peripheral vascular disease. The last task 2, which was held in 2007, we are still following the guidelines, and there was a supplement in 2015. So they suggest ABI should be measured in certain category of patient, not only in patients who have come with the exertional limb symptoms. Now, why do we need to measure the ABI in all these patients? Because whenever a patient has a PAD, now PAD is a disease in itself which is threatening for the limb. Apart from that, it is a marker of the underlying cardiovascular disease. So if you look at the patient who has been diagnosed with the PAD, now when we say PAD, it means ABI is less than 0.9. That is a diagnostic definition of a peripheral arterial disease. We are concerned with two things: major adverse limb events and major adverse cardiovascular events. So all the risk factor reduction strategies will be targeted to both of them, and the revascularization strategies will be targeted to prevent the major adverse limb events. You see, there is an exponential increase in the odds of having the cardiovascular events as the ABI goes down from 0.9 downwards. So ankle brachial index, very simple to take, gives us so much information about the peripheral arterial disease and the cardiovascular health of the patient. So these are the things which you can get. It can tell you the severity of the PAD, it can see you the cardiovascular disease burden, and we can gauge the treatment according to that. So as the disease of the underlying stenosis progresses from the normal to the stenosis to the occlusion, you see there is a consistent change in all these physiological parameters correlating with the Doppler waveforms. TBI keeps on decreasing from the 0.6 downwards, and then you have the gradual decrease. So there is a consistent change in all these physiological parameters as the disease progresses. So now we have diagnosed a peripheral arterial disease for which we don't need radiological imaging except in certain circumstances like diabetic patient you have ABI more than 1.4. It's the role of further imaging. Now the role of the further imaging comes in patients whom we have decided to intervene. We want to do a revascularization therapy, and the patients who have moved over the heel, and if you see the CPVRD here, you can see there is a, you can think it is a posterior tibial artery, okay fine, I'll go and just plasty and come out. But this is not the contrast, this is all is a calcification. So if you have calcified arteries, it is difficult to come to a conclusion in CT because it will be dense. Contrast will also be dense. So now you see, you compare here, we did a DSA for this patient and the PTA, there is hardly any flow, contrary to what CT angiography shows. So we end up doing a peroneal angioplasty in this patient. Now this calcific problem to some extent can be mitigated by a dual energy CT scanners, where what you do, you use two different energy levels, different kVs, and you can subtract the calcium out of the vessels. But it is I don't think it is available much of the places. So in this patient, for example, you see aortoiliac disease, there is a calcification. Now here you have subtracted the calcification. So you can clearly see the severity of the occlusion. Coming to MRI, is gradually becoming a first-line imaging modality, even better than CT angio, because of the robustness and no limitation of the calcification. So there are multiple modalities and multiple techniques available in the MRI which will able to generate a DSA-like image even without giving a contrast. So the techniques which we employ in MR angiography are the contrast image and angiography, which is almost equal or sometimes better than digital subtraction angiography. However, if the patient has a CKD, because these patients have diffuse diseases, many of the times they are they have some kind of renal dysfunction, so you can do a time of flight MR angiography which does not give any contrast to the patient, still generates a good amount of information. For example, now you see this is you can visualize the whole tree on the contrast MR angiography. This is a patient who had undergone aortobypass bypass, and you can see the bypass seems to be intact, and there is a clear depiction of the SFA stenosis in both the sides, and you see the crural vessels as well. So it is becoming a modality of choice. The only limitation which remains is the robustness of acquisition of the images and the artifacts, because it requires the stasis. I mean, patient does not have to move, it is associated with a lot of motion artifacts. If can generate a good MR angio, then it is a one-stop shop solution for all the problems. There is a time of flight MR angio which does not require the contrast, but see the quality of the images which are generated. Now this is the calcification. You see a CT angio, you cannot say whether this vessel is patent or not. This all is a calcification, but on MR angio you can see clearly that, so there are few areas of stenosis and occlusion, but you can trace the well. So calcium is not a limiting factor as contrast to CT angiography. So how do you choose what to do? Now patient has come to you, he has a CLI or a severe claudication. So you cannot say you go to the CT, if the calcium comes then we will ask you to do an MRI. You have to decide on one imaging modality. So it will depend on the clinical context of the patient. If it is a native vessel, that is if the patient has not undergone any of the intervention before, either CT, MR or duplex ultrasound is enough. The only limitation of duplex ultrasound is that it will not give you a global view, or the whole tree you will not be able to see as you see on the CT and MR angio. The only thing is that if the patient has an underlying calcification, which you will be able to decipher from the ABI. So what we do, if the patient has an ABI of more than 1.4, then we ask the patient to get an MR angio done rather than the CT angio. Rest of the patient, both are almost as good depending on how you acquire the images. Now if the patient has undergone a bypass, so you can just use a duplex ultrasound for evaluation surveillance of the same. If the patient has undergone stenting, then CT angio is preferred because MR will give you a lot of artifacts because of the metal. So the diabetic patients suspecting medial artery sclerosis, contrast and enhanced MR is preferred. If the patient has the renal insufficiency, again you can do a non-contrast MR angio, which will be better and you don't have to give a iodinated contrast. So still the consensus of the gold standard is digital subtraction angiography. Whenever you have a doubt, you are not able to see the distal target vessel, you should go for a digital subtraction angiography, which is still the gold standard. You see the clear cut. Also it will give you a good information about the collaterals and the chronicity of the lesion. So these are the stenosis in the SFA. The only drop. So in fact nowadays some of the groups are promoting digital subtraction angiography as a gold standard before doing an amputation. The thing is that because of the advances in the endovascular intervention, now people are doing inframalleolar angioplasty, pedoplantar root reconstruction. So these small vessels are better seen on the digital subtraction angiography rather than that. So before doing an amputation and ruling out the possibility of any endovascular intervention, you have to do a DSA. So this was a paper published in one journal from the CLI group. So they recommended that we should do a DSA before getting a patient for amputation. So limitations, it is an invasive procedure, requires a contrast and so on. My take home message is ABI has been stressed in the first lecture also, is the most important parameter to diagnose and prognosticate PAD. So diagnosis of PAD is ABI. Patients with mild intermittent claudication who are being managed on conservative management need not have to undergo any of the investigation after that. Indications of the imaging should be very, very clear. What we are looking at, why do we want to image this patient, and what kind of imaging we want to use. We have to optimize and ask the right question. Consider MR over CT angio in diabetes mellitus patients, or if they have an ABI of more than 1.4. DSA is can be considered in equivocal cases, and the duplex should be used maximally because of in post-interventional surveillance, because it does not require any radiation and is a very cheap modality. Thank you so much for your time. Any questions?
So coming here, working in the private sector, we are usually having on single mortality like ultrasound, Doppler ultrasound.
Yes, yes.
And if it is coming with some problems, the lower limbs, the single mortality, how you will do?
Sir, you do a ABI because I mean, before I got into interventional, I did my fellowship in intervention and starting in the PADs, then I realized the importance of ABI. It is the most important, as I stressed again and was stressed in the first lecture also. If the ABI is 0.9, I mean not more than 0.9 to 1.4, then you almost rule out the peripheral arterial disease. And it will give you a very good idea of how you have to proceed afterwards. So, if you are planning, if the patient has come with a CLI, you know the ABI is 0.5. Now you have to intervene. You have to do something about the patient because the treatment of choice then becomes the revascularization. Now you cannot take the call of revascularization on the duplex. You have to do some kind of CT or MR angio. So that is how you have to plan your listing. Any other questions?
So, if you the color doctor, so what are the criteria to be able this patient is admitted to discuss on that? I mean, how to differentiate between the non-significant from the significant arterial disease on the duplex dog?
On duplex? Sir, you can do because at the waveforms, as the Dr. Rajesh has already discussed, there is a triphasic waveform and there is a monophasic waveform. If you see a monophasic waveform in the distal circulation, you know there is something proximally. So you can trace the whole tree in the duplex as well and localize. It's not like you have to do CT and MR, but most of the time when we do kind of intervention or revascularization, because we have to plan the axis as well. Suppose I am doing a IO2 eyelid, I have to see how much margin I have from the puncture site from CFA to the distal lesion, so that I can place a 11 centimeter sheath there. So for that kind of intervention and revascularization, I think that will be better seen on MR or CT angio.
What is the value of PSVR, peak systolic value ratio? Are you taking on the patients?
Yeah, so basically PSV will tell you the site of the stenosis. If it is not occluded more than 80-90%, then PSV will higher the PSV, higher is the stenosis. So how you judge the hemodynamic significance of the stenosis? That is the way you do it.
If it is more than 2:1, then
Yes.
With the mild intermittent claudication cases, as you said, radio imaging is not done. But are there chances of having any radiological imaging changes if you have noticed it by chance? Because that is also the point that apart from medical treatment, you can actually look into it, maybe reversal is possible.
Yeah. So ma'am, basically see, you have to treat, that's what the message was, that you have to treat the disease. Even if there is a disease and patient is compensated, that is if his ABI is okay and has a mild symptom, so you will not do anything for the patient. So there is hardly a role of prophylactic intervention. So unless and until patient has the symptom, you will not do anything about it. There is no point in doing CT or you can do a Doppler if you want to localize the site of the lesion, that will more than enough. But I don't think we have to go for the CT or MR angio in these cases, in cases of mild symptoms. There is no need, because even if there is that is there, you will not do anything, and you will not follow up these patients on CT or MR to monitor the therapy.
With 0.7 to 0.9 ABI, which is mild disease, what are you doing any intervention for it, or is it needed, or it is not needed? Just an imaging or a color doctor to symptomatic patient is needed.
Yeah. So if the patient 0.7 to 0.9 ABI, now that will depend which category the patient falls. It is Rutherford category 3, 4, 5 disease. If patient still has some kind of tissue loss, if it is a gangrene, then clinical will override the ABI. So if it correlates well, but if clinically you see there is a gangrene in the patient and there is something underlying, then you have to image that patient and see what you can do. Clinically you have to take all your decisions. Any other questions? Thank you so much.
Thank you so much, respected sir, for this wonderful and extremely engaging and informative session. It's my humble request to chairpersons to please felicitate Dr. Aman Kumar sir with a memento. Please sir, please ma'am. Now it's the time to move towards the final lecture of the session 2, for which I wish to invite Dr. Viren Shiorin sir to express his views on the topic intravascular ultrasound in peripheral artery patient. I would also request our chairpersons to please introduce sir to us.
I would like to welcome Dr. Viren Shiorin. He is a senior consultant interventional radiologist at Vedanta Hospital, Gurgaon. Dr. Shiorin has more than 15 years of experience in vascular and interventional radiology. He is a graduate and postgraduate of Nagpur University. He pursued his vascular interventional radiology training in peripheral and neuro intervention from prestigious institutes like AIMS Delhi, George Washington University, USA, University of Texas, USA. He has special interest in the areas of peripheral artery and aortic disease. Welcome, sir.
Thank you so much. So I will be talking on intravascular ultrasound. We have seen CT, MR, angio and other extravascular ultrasound. And I will be talking on how important an intravascular ultrasound can be to make a decision while doing a peripheral arterial and venous aortic interventions. So IVUS is basically an intravascular ultrasound. So what we are looking in an extravascular ultrasound, we are looking from outside in. Here we are looking from inside out. It's a specially designed catheter with a tiny ultrasound probe attached to the distal end. In India, we have from two companies, which is Boston and Philips. Both are a little bit different. One is static and the other one is basically a rotatory kind of IVUS. So it is to see from inside of the vessels outside, and why there was a need, because extravascular ultrasound has a limitation. You cannot see in detail the inside of a lumen, and when the vessel is really deep, it becomes a problematic thing. So it's the only imaging modality that can differentiate a static fixed true stenosis from a dynamic stenosis. When you're doing a DSA, there are multiple questions which comes many times, whether this is a flap, whether this is a thrombus. So everything can be ruled out without a non-ionizing method, and which is an ultrasound. Highly sensitive and accurate, and hence minimizes the chance of missing lesion that could compromise the outcome. Not only helps to locate the lesion and helps in precise stent treatment, but at occasions it prevents unnecessary stenting. In imaging, when you are doing a DSA, you have to take multiple oblique runs. Here you can avoid those. So this is an example of intravascular ultrasound from IVUS. So I will be boring a bit with this black and white images. So there is some issue with the laptop images. I'll have to look here. Okay, so for the beginners, I mean, for a radiologist, IVUS is again an extension of their black and white imaging, I would say. But for a cardiology guys or a vascular surgeons who don't have a real background with black and white imaging, that would be a little challenge. So always you can compare it with the DSA or a rollback imaging, and you can, it's basically by convention it is a full back. So it's basically a full back of the IVUS catheter. That's the norm or the convention, in which you keep on pulling and look for the stenosis, where thrombus. So there it's an example of basically a thrombus inside the lumen, and here you can nicely see it's opposed to one of the wall. So I'll be showing you the examples. Again, IVC with the stent. So how the stent causes artifacts, so one should be aware of while doing the IVUS. So these are the stent characteristics. Again, a kissing stent has been placed. In this we place two stents, sometimes from both the IEX into the IVC, and one should be aware of while looking at the IVUS imaging. So it's a very, the most important or the useful usage of IVUS is while doing a DVT. When you're doing a deep vein thrombosis treatment, when you have basically cleared all the thrombus and you have done a balloon angioplasty of the common iliac vein, then with the IVUS you can easily find out the exact site of May-Turner syndrome. which is basically a compression of the common iliac vein between the vertebra and the artery, and the lumen or the area is really decreased, and hence you can take your call whether this needs angioplasty with a bigger balloon or you go with a stent. Here a stent was placed, and then here you can see the area is increased. So you can also decide whether the stent is completely open or not. So again, an example of extensive compression over the vein from the lymph nodes. This we can easily miss with just plain DSA or angiography. These are few more examples of deep vein thrombosis. Here you can see chronic thrombus layering within the vessel. Few examples of where sometimes there is an entity called non-thrombotic iliac vein lesions in which there could be web or other pathologies which can lead to DVT, and May color is not the cause all the time. So IBUS can again give a nice picture and display of the lesion which is inside the lumen. This is again false positive respiratory. So sometimes when you are doing an angiography, you see the lumen is nicely compressed, and if you do again, it may be opened up. So IBUS, if you go ahead and do at the same side, you will see a dynamic motion, and hence you can avoid placing a stent at this side. So I will be sharing few of the examples where we have used it. So this was a case of basically an AV fistula in which we had there was central venous stenosis in which we had gone inside. So we were worried whether to place a stent or not, and here we could easily make out there was a real dynamic compression because of the aorta into the left brachiocephalic vein, and being that we are going to put a stent here, it's going to fracture and won't last long. So patient was explained she was pretty young, and then we refused to place a stent. So here the IBUS played a very important role for making a decision where the stent should not be placed. Similarly, you can see a pancaking effect on the DSA. Here IBUS again shows there was a compression. You can exactly measure the size. You will be confident in sizing the stent, because in DSA sometimes we are worried whether the stent will migrate or not, and then a stent was placed where you can see nicely opened up a lumen with the artifacts of the stent. Another scenario. So this is a typical May runner. I have just done a pullback run, and there this becomes a linear basically graph here, and at least you will see the arteries nicely compressing the common iliac vein, and this is pre and post stenting. So May runner, the IBUS plays a very important role. Now coming treatment of this May Turner syndrome, we have placed a stent. It's an oblique stent. We were happy. Patient was sent back to room, and next day on check doctor, he could see the stent was completely occluded. So we took the patient back, and then what we found was, so this was day one, everything looked fine, and next day the stent was thrombosed. Now we knew there is something going on at the distal end or the cranial end of the stent. So IBUS was done after clearing up the thrombus obviously. So IBUS showed there was some flat plaque at the distal end, and here you can see. And then we went ahead with our angiojet, which is a thrombectomy machine, and we cleared up the thrombus, and then finally, so this here you can see with the pullback run at the distal end. So maybe we missed it, or there was something technically we should have extended our stent a bit higher. But if we didn't have a thrombus, then we would have been trouble, and we would have blindly placed it. So with cleaning and ballooning it worked well. And here you can see with the pullback run looks good. And there was clearance of that distal. So this is another interesting case, chronic DVT. Patient is having a non-healing ulcer for 10-15 years, around 70 years old. So a CT was done. I will show you the X-ray images. CT was reported to be normal. You can see. When I had seen this CT, there was obviously no frank lesion to call it any iliac or a proximal iliac lesion, but clinically it was not matching. So patient was advised varicose vein surgery somewhere, but he came and we knew that there is some issue with the proximal vein. He obviously did had a history of DVT. So him, the plan was to do a venogram and an IVUS together. In venogram there was a pancaking. Here you can see there is some kind of washout and flat like common iliac vein, but IVUS was very diagnostic. Again we could see, if you look at the area, when we pull back, both the walls of the common iliac vein comes and approximates the IVUS catheter right where that pancaking is. So we knew there is a compression or a dynamic compression going on, and which made us confident that we go ahead and place the stent and see how the hole hits. So once we went and we placed the stent, you can see within a couple of weeks there was change in the size of the wound, and wound almost completely healed within a month. So this was another case, similar case. So I won't be going in detail. Similar case, underwent EVLT, was not healing, and then we went ahead and then we placed stent. There was dynamic operation. Coming to role of IVUS in aortic intervention. Again, it plays a very important role, especially when you are doing dissections. Here you can see, it is not that you cannot do it under DSA, but IVUS gives you another third eye where you are pretty confident. Here you can see once we have gone in and the false lumen and we have placed exactly into the true lumen. So that is another advantage of IVUS in aortic cases. Another case, here patient came with a midline, we didn't have a stent graft to see the proximal acute limb. So we had to go in and do a fenestration. Fenestration is nothing but creating basically a hole between a true and a false lumen, or making a bigger hole so that the pressure between the two is equalized and the false lumen is basically depressurized, and the flow towards the limb increases. So here you can see the IVUS catheter is within the true lumen, the rest is false. So the plan was to go ahead and puncture it with a sharp. You can take the back end of a wire, you can take any sharp needle long, and then under IVUS guidance you can see the needle was penetrated from true to false lumen, and then over that wire, here you can see that the needle is going across. So we have penetrated. Scenario. This was a case with bilateral varicose veins, young chap, left-sided varicose vein. So we knew that there might be some reason which is causing him varicose vein. Significantly, it was on the left-hand side. So we just show the run the video. So we treated varicose vein predominantly on the left side, and then we used our IVUS to see. So there was again a compression of the left common iliac vein, and IVUS was done. So this compression was basically leading to secondary varicosities. We have advised this kid that in future he may have to be very careful, and he may need future plasty or so. This is how we did a balloon test as well. So we did an IVUS. Finally we treated the disease, but he is again prone. So IVUS helped here as well. It was done under local anesthesia. So this is one more example. Nowadays hemodialysis is so rampant, CKD numbers are pretty high. So we place tunnel dialysis catheters. It's placed by IR, DEFRO, a lot of people place it. But there is recurrent occlusions of the hemoport or the tube permacath, or the tunnel dialysis catheter. What happens is a fibrin sheet or a forms over the catheter which blocks the hole, and the flow basically stops. So here again IVUS plays a very important role. So you go do a venogram, you can see the fibrin sheet jacket. You remove the catheter out, you do a venogram, and then with the IVUS you can see there was that fibrin sheet, and once this fibrin sheet, so there is various ways to break this fibrin sheet, do a balloon plasty, do smearing. So that's all we have to have. We can talk for 30 minutes on different techniques to remove the fibrin sheet. But IVUS does have, so that's the fibrin sheet, nicely seen across the catheter, thick fibrin sheet. So once an intervention is done, plasty is done, when it's broken, so you can see and make sure, we do a velogram, but IVUS does help to see that the sheet is broken and macerated, so that the flow is again restored into the runner dialysis catheter. Another advantage of IVUS. I will go more, so I will conclude my talk by saying IVUS is an indispensable tool when assessing and treating patients with complex aortic, iliopathic, arterial and venous pathologies, brachiocephalic subclavian pathologies as well. It provides safe, accurate and reproducible information that prevents under or over-treating patients and thus improving clinical outcomes. And yes, it is totally safe to patients and operator. I mean, it saves a lot of radiation to the operator. And IVUS should be part of vascular IR armamentarium, so it's an indispensable part and should be in the IR department. Thank you.
Thank you, sir, for such a wonderful talk. Sir, I would like to know the cost of this
IVUS. Yeah, so IVUS catheter MRP 60,000, the Philips which we use. But the good part is it's very robust catheter and it can be reused for 10, 15, 20 times. That's the great advantage with this catheter. So it's very robust.
Any questions?
Sir,
Yeah.
wonderful cases as usual. I just have one question. The patient will, with non-iliac ulcer, you had stented. So that pancaking, why was it missed on the CT? Because cross-sectional imaging would show us the compression always. Maybe it's a CVO or a Mayhardner. So
I agree, and they could have done a very well because what images I get in my OPD were higher than hers. But it was reported by a very senior radiologist, and patient was even arguing with me that CT is normal, so why should we go with the procedure? But clinical picture is never wrong. Imaging can be missed, right? So we explained in CT, I can share with you, but I scrolled at 5 images and I could not really see to make it say that there was real stenosis. Most likely they are dynamic kind of.
maybe by the time the CT was done, it was inflated. It's a dynamic, so it's not a
Most
real.
likely it's a dynamic. Latest CT images which you have shown with the higher ones, maybe we can catch them. Most of the times for venogram I don't believe CT because most of the time it's written the other way around. So either we do our own Doppler or if we are doing so it's very handy, it's in the cath lab, so it takes 10 minutes. So you take a 9-foot sheet and you just put a catheter and you pull it out. Cost is not an issue because it's reusable.
Sir, another thing, when you see a compression of the IVUS, so how do you assess the hemodynamic significance? Because that compression is seen many patients when you do CT, CCT.
So I agree, like the thing is we are doing in all the symptomatic patients. Think the other way around. And there is no other finding. So we don't take pressure, so we are not doing on a normal subject. So all the patients are coming with massive swelling of the upper lip or they are coming with some non-healing ulcer. So they come in a very terminal state. And if there is no other cause, probably that's the only cause. I mean, thinking the other way around.
Thank you, sir.
Thank you so much, sir, for this enlightening and enthralling talk. I would now request our respected chairpersons to please felicitate Dr. Virendra Sheorin, sir, with a memento. Please, ma'am, please, sir. Thank you, ma'am. Thank you, sir. It's time for us to felicitate our respected chairpersons for the session, for which I would like to invite Dr. Ratnesh Jain, sir, to please felicitate Brigadier Dr. C.M. Verma, sir. I would now request Dr. Manohar Singh Rathore, sir, to please felicitate Dr. Rajendra Bhojwani, sir. It's my humble request to Dr. Megha Mittal, ma'am, to please felicitate Professor and Head of Department, Dr. Akshara Gupta, ma'am, with a memento. Thank you once again to all the respected chairpersons and guest speakers for sparing your valuable to my colleague Dr. Aishwarya for the further conduction of session 3. Thank you.
Thank you, Dr. Apurva, for such a warm welcome. Good morning to all. Myself, Dr. Aishwarya Kulkarni, on behalf of all of organizing, once again welcomes you all. Moving forward towards the third session on management of peripheral arterial disease and recent advances in endovascular therapy. This session consists of five highly informative lectures. I take immense pleasure in welcoming our respected chairpersons for the session. Dr. O.P. Jadhav, sir, Professor and Head of Department of Medicine. Dr. Achal Gupta, sir, Senior Surgeon. I request all respected chairpersons to take their seats, please. I hope all of you have gained a lot from the previous sessions. Keeping on this trend, I welcome Professor Dr. Prashant Srivastava, sir, to share his knowledge on medical management of peripheral arterial disease patients. I also request our respected chairpersons to introduce sir. Please, sir.
Yeah, good morning. The lecture by Dr. Prashant is medical management of PAD patients. I don't think Dr. Prashant needs an introduction here. He is a professor and head of the surgery department in Medical College Gwalior. He did his MBBS MS from Medical College Gwalior, and then he went to do urology from AIMS, and currently he is heading the chair. So Dr. Prashant, for your lecture, please.
Thank you, respected Dr. Achal Gupta, sir. He is my revered teacher and guide during my MS. I thank Professor Dr. Akshara Gupta, madam, and Dr. Manohar for giving me the opportunity to speak on this topic. So I think the definitions, this is more important for initial management of peripheral arterial diseases, and this talk is aimed for our residents who see these patients in surgical OPDs and also for physicians who are here. So because we can diagnose, we can have the idea that this patient is having a peripheral arterial disease early in the course, and we can instruct these patients certain measures which can prevent these complications which threaten the limb and can sometimes delay the progression, definitely. So, starting with what is peripheral arterial disease. Peripheral arterial disease is a chronic atherosclerotic disease of the peripheral musculature resulting in limb-associated complications. And what are these limb-associated complications? Intermittent claudication, ischemic rest pain, ischemic ulcer, gangrene, and functional impairment. Now, it's a relatively common condition. Around 220 million people are affected worldwide with an increasing prevalence day by day. It is often a harbinger of this atherosclerotic disease elsewhere in the body, especially the coronaries and the cerebrals are also affected in PAD, are commonly found affected in PAD patients. Now, what is the impact of peripheral arterial disease? There is a significant impact in terms of quality of life and financial well-being of the patients. Patients with both CAD and peripheral arterial disease have increased risk of cardiovascular mortality than CAD alone. And there is an increased risk of adverse cardiac events in these patients. And the sequelae requiring amputation increases the mortality to around almost 50% at 1 year in patients with peripheral arterial disease. Now, the treatment. Therapies are directed towards management of claudication symptoms, secondary prevention of cardiovascular complications, and limb salvage. The treatment strategies include lifestyle modifications, medical management, endovascular therapies, and surgical interventions. Now, the medical management encompasses, but not restricted to all these, cholesterol reduction, antiplatelet therapy, anticoagulation, peripheral vasodilators, blood pressure control, smoking cessation and tobacco abuse cessation, and exercise therapy. We will discuss these modalities one by one. Now, a word about major cardiac events. I think it was discussed in the first slide. These include non-fatal stroke, non-fatal myocardial infarction, and cardiovascular death. Now, coming to cholesterol reduction. Now, as we all know, increased lipids and lipoproteins, especially the non-high density lipoprotein ones like total cholesterol, non-HDL lipoproteins, and LDL cholesterol. These are associated with increased risk of atherosclerosis and cardiovascular diseases, and therefore PAD is no exception. Research on statins, ezetimibe, and PCSK9 inhibitors indicate that lowering lipids, especially LDL cholesterol, to the target greatly improves the cardiovascular outcomes. Statins, statin therapy, as compared to non-statin measures to lower cholesterol levels, they addresses both limb-specific and systemic complications from peripheral arterial disease. Statins have a direct anti-inflammatory effect in patients, thereby stabilizing the atherosclerotic plaque and reduce the vascular events. Now, what is high intensity statin therapy? Is rosuvastatin in the dose of 20 to 40 mg daily, or simvastatin in the dose of 40 to 80 mg daily. This high intensity statin therapy reduces major adverse cardiac events in cardiac patients. Coming to ezetimibe, is a cholesterol absorption inhibitor. In very high risk patients, statin therapy alone is not sufficient to reduce the cardiovascular risk. Very high risk patients are those patients who have multiple comorbidities and a history of cardiovascular events, or there is a past history of multiple cardiovascular events. So in those patients, this ezetimibe is indicated along with statins. Now, the AHA recommends, it's a class 2A recommendation in very high risk patients with LDL cholesterol of 70. Despite maximally tolerated statin therapy, an addition of ezetimibe is indicated in these high risk patients, very high risk patients. According to recent studies, ezetimibe without statin therapy is not alone sufficient in the management of PAD in very high risk patients. There was an improved IT trial, that is improved reduction of outcomes, Victorian efficacy international trial in 2016, which randomized patients with recent hospitalization for acute coronary syndrome to receive ezetimibe or placebo alongside moderate intensity statin therapy. The results were high-risk patients, 18% of those who had PAD experienced the greatest benefit from ezetimibe. Now coming to PCSK9 inhibitors, these inhibitors, they there is a class 1A recommendation of aspirin, low dose aspirin in peripheral arterial disease patients. Now the second antiplatelet drug, which is a P2Y12 receptor inhibitor, there was a Capri trial, clopidogrel versus aspirin in patients at risk for ischemic event, has shown a nearly 25% reduction in primary endpoints of vascular death, non-fatal MI, and CVA in patients with clopidogrel over aspirin. And there is a recommendation, class 1A recommendation from ASA for the single agent antiplatelet therapy in patients with peripheral arterial disease. However, the guidelines, even despite the results of these Capri trials, the guidelines do not recommend clopidogrel over aspirin for the management of PAD patients. Now, another antiplatelet drug is ticagrelor. It's a newer P2Y12 inhibitor. There was a trial, Euclid trial, which was based on that examined use of ticagrelor in peripheral arterial disease. It compared clopidogrel and ticagrelor in almost 14,000 symptomatic peripheral arterial disease patients to determine whether or not ticagrelor was the better agent in PAD. The outcomes were the primary endpoints of cardiovascular death, myocardial infarction or ischemic stroke was not significantly different between the two agents, and therefore ticagrelor is no better than clopidogrel in peripheral arterial disease. Now, a word about dual antiplatelet therapy. There was a trial, Charisma trial, in which clopidogrel for high enterothrombotic risk and ischemic stabilization management and avoidance compared dual agent antiplatelet therapy to single antiplatelet agent and included patients with peripheral arterial disease. The results were there was no significant difference in the fatal complications in the two groups. However, the risk of bleeding in some of the cases was slightly higher in the dual antiplatelet therapy group. Now, coming to anticoagulation, the most serious limb complication of peripheral arterial disease is primarily an atherothrombotic disease. Now, there was a landmark study by Nebula et al. In 2018, which showed that almost 3/4 of parties taken from patients who underwent amputation secondary to CLI showed luminous thrombi without the evidence of local site atherosclerotic disease. This is very important. They were thrombi. So, without the evidence of local atherosclerotic disease. Therefore, the stenosis or leading to complications of peripheral arterial disease leading to chronic limb ischemia, that is limb-threatening ischemia, are a thrombi-dependent mechanism. And in the pathogenesis of many patients with peripheral arterial disease and limb-related complications. Warfarin. The OSIS trial and WARIS-2 trial showed a combination of warfarin and aspirin was better than aspirin alone at preventing major adverse cardiovascular events. However, in a newer wave trial, there was no significant difference in occurrence of major adverse cardiac events between patients receiving combination of warfarin and platelet and aspirin than warfarin alone. However, the risk of bleeding was more when the combination of two was used. Rivaroxaban and apixaban, these are factor Xa inhibitors. There is a potential benefit of increased patient compliance and lower likelihood of major bleeding compared with warfarin. Low dose rivaroxaban, that is 2.5 mg twice daily, and aspirin reduce major cardiovascular events and adverse events over aspirin alone. There is a class 2B recommendation from AHA. There was a trial, this came out after a trial that is called COMPASS trial, and before this COMPASS trial the results were out. The American Heart Association included this drug for the treatment of peripheral arterial disease patients under level of evidence category class 2B. Now, the role of peripheral vasodilators. There is intermittent claudication. It represents a peripheral arterial ischemia secondary to or distal to the stenosis of the narrow segment, and this is brought about when there is exertion. This supply-demand mismatch is often a result of stenosis. Thus, insufficient vasodilatory response will result in symptoms that are relieved by rest. The AHA guidelines include a class 1A recommendation for silastazole in the treatment of symptomatic claudication. Silastazole inhibits platelet aggregation. Silastazole increases exercise tolerance over placebo. There was a systematic Cochrane review of 15 trials in 2016, which the results were that silastazole increases exercise tolerance, and there was improvement in mean walking distance or claudication distance by 21.4 meters in this Cochrane review. However, as compared to this Cochrane review and the role of silastazole in improving the claudication distance, the supervised exercise programs, they cause a much larger improvement in the claudication distance. That is, by around 150 meters, there is a 30 to 25% increase over the baseline distance, and this was found sustained at 6 months. This drug silastazole is contraindicated in patients with high heart failure. There has been found to be higher cardiac mortality. The common adverse effects are headache, palpitations, and diarrhea. Because of these side effect profile, heart failure risk, because there are a lot of comorbidities in these patients, there is a lot of pill burden, and only subtle benefits as compared to exercise and other agents. This drug is used infrequently, and it should be considered in only well-selected patients who have refractory claudication and who are able to tolerate the drug. Now, blood pressure management. As we all know, a higher blood pressure promotes atherosclerosis, and therefore antihypertensive therapy is important, assumes an important role in addition to other therapies for the management of peripheral arterial diseases. According to 2017 AHA guidelines on hypertension, antihypertensive medication is recommended for patients with cardiovascular disease and systolic blood pressure of more than 130 and diastolic blood pressure of more than 80. The target BP in peripheral arterial disease should be less than 140 systolic and 90 mm mercury diastolic pressure. There is a class 1A recommendation from European Society of Cardiology. Control of hypertension is an important facet to medical therapy in peripheral arterial disease, but it remains to be seen whether ACE inhibitors or ARB like telmisartan, and this is angiotensin receptor blocker, offer benefit beyond blood pressure control in PAD. Further studies are needed in this regard. Now, a good glycemic control obviously prevents further atherosclerosis progression, and therefore there is a need for glycemic control. The specific goal of hemoglobin A1C should be set to less than 7% in these patients. Advantage of using metformin as an hypoglycemic agent for patients with type 2 diabetes and chronic limb-threatening ischemia is there over other drugs like insulin and others, because metformin has an anti-inflammatory, direct anti-inflammatory and pro-mitochondrial properties which help in prevention or reduction of progression of atherosclerosis in these patients. Now, tobacco abuse. This is a common comorbid condition associated with many patients with peripheral arterial disease, especially those with CLTI. Smoking is a single greatest modifiable risk factor for the development and progression of peripheral arterial disease. Tobacco smoke causes endothelial injury by the reactive oxygen species and leads to atherosclerosis within these vessel walls. And when this tobacco abuse is associated with peripheral arterial disease, there is an increased incidence of adverse cardiac events. Clinical support, adjunctive medications like nicotine replacement, bupropion, and varenicline, and counseling should be offered to all active smokers with peripheral arterial disease. It must be realized that it is very important to ask the patient to quit tobacco, and counseling is very important part. Now coming to exercise. There are clear benefits for patients with peripheral arterial disease and intermittent claudication, and it should be attempted prior to revascularization. Patients should be referred for a supervised exercise program. With an exercise physiologist, it is better than the outcomes are better when these programs are supervised as compared to when it is unsupervised. It increases calf blood flow, improves endothelial function, and reduces local inflammation, and induces angiogenesis. The recommendations are patients should perform a minimum of 45 to 60 minutes of exercise at least 3 times a week for 12 weeks, typically walking on a treadmill, and the intensity should be enough to cause the starting of claudication pain. So to conclude, peripheral arterial disease is a devastating disease with high morbidity and high mortality. A number of medical therapies exist to reduce cardiovascular mortality as well as prevent progression, limb loss, and need for invasive interventions. PAD is chronically undertreated relative to coronary artery disease. This is a well-known fact, and therefore many patients suffer limb loss. And future advancement will definitely help in formulating strategies, better strategies to improve quality of life for patients with peripheral arterial disease. Thank you.
Thank you. The person very detailed and very
talk really so many recommendations and so many studies. But one thing which I see in my clinical patients, we have not talked about Burgess disease, which we Indians are fond of diagnosing. It may not be Burgess of a time. 70-year-old male patient coming to me with a psoriasis or a lesion within Burgess disease, not Burgess disease. But still we do see patients, young patients, 25-year-old male patient with a. Now, do you have the same recommendations which you have quoted here for those patients, or they do need something else apart from all this?
These recommendations, they are generalized for the patients of atherosclerotic disease, which involves the major and medium-sized vessels, and the Buerger disease, which involves the medium and the small-sized vessels. So, because atherosclerosis do exist in many of these patients, along with the thromboembolitis, that is the inflammation in the vessel wall, which involves the veins as well as the nerve. So these recommendations are there for those patients as well, because we cannot rule out until we have done a biopsy, or we can for intravenous venography, intravenous ultrasound, to see that there are plaques which contribute to this process. So because these are not mutually exclusive, these recommendations do stand for Buerger disease.
I see this is a description.
Any role. In fact, they can.
No further questions?
Good morning once again. I hope all of us are having a good time in this session, and it was really an informative talk by Dr. Prashant. So for next 15 to 20 minutes, we will see the role of endovascular therapy in patients diagnosed with peripheral arterial disease. So the agenda in the next 15-20 minutes will be to understand what is the need for revascularization in patients with PAD, what set of patients will really benefit from revascularization. For example, if patients intermittent claudical, when you should consider revascularization. CLI patients, you have to try revascularization some way or other if possible at all. Technical aspects of endovascular therapy, what are the options available, and the different segments. You will see cases for these different segments, behave differently for endovascular therapy as well as for open surgical repair. So again, coming to the task guidelines, they give you an overview of the, if you look at the natural history of the PAD patients, as we discussed in the previous talk as well. So across the spectrum, if you see the natural history, these patients, if not dead, in one way or other will progress to have either cardiovascular events or adverse limb events. Now these cardiovascular events are usually dealt with the reduction in the risk factors. Dr. Prashant already explained how we have to deal with that, and some of the drugs which might benefit these patients from progression towards. What we have to do, we have to halt the progression from asymptomatic to the CLI, and if the patient has come in the stage of the CLI, we have to prevent the progression to the amputation. So the target is to increase the quality of life and decrease the rate of amputations. So what happens in the PAD? So starting with mild intermittent claudication, as the plaque increases and causes more stenosis, patients are prone for increasing severity of the claudication, rest pain, and sometimes the vessel may close down and result in ALI or tissue loss with chronic limb ischemia. So need for revascularization in patients with severe claudication, rest pain, tissue loss, or before patient has come and he can do before amputation, before taking a patient for amputation, one must consider revascularization to allow the good healing of the wound, otherwise there will be problems. After amputation, if the wound is not healing because patient has not undergone endovascular or revive, one should consider revascularization therapy in this of patient as well. So coming to the Rutherford classification, we know these categories, mild to moderate claudication and even severe claudication, should at least get a trial of the conservative management first, 4, 5, 6, they need aggressive revascularization. So these are the pathway for the task 2 pathway for non-CLI patients. All the risk factor reduction plus some of the medications. Now there is a role of anti-thrombotic novel oral anticoagulant as well. So you must to try all these modalities to downstage the patient from RC3 to RC1, mild claudication or no symptoms at all. And even after that, if the patient progresses or continues to have the symptoms of life-limiting claudication, can be considered for revascularization after undergoing a non-invasive vascular evaluation. So in cases of intermittent claudication, most of the guidelines recommend a primary revascularization in all the patients of IC. It's not indicated. One should get a trial of the therapy. In patients with lifestyle limiting claudication, for example 50 to 60 meter depending on the patient, it may be considered and a trial should be given. So that is the conclusion. However, in patients with CLI, revascularization is the treatment of choice again. So what are the tools of revascularization we have in PAD? So endovascular has evolved a lot in last 10 years, ranging from the plain angioplasty, then placement of the stents to increase the patency of the angioplastic segment, self-expanding segments, atherectomies. Now, the best form of treatment which can be given in the fibropopliteal or movable segment is the atherectomy followed by drug-coated balloon angioplasty. So these are the drug-coated balloons which impregnate paclitaxel into the wall and decreases the re-stenosis rate in these segments. Covered stents, so there have been a lot of trials and also there is an online method. Dr. Veeran will speak on all these latest developments in the PAD. And then we obviously has a time-tested bypass procedures. Aortoaortic bypass, PENPOP and distal bypass, which are time-tested and proven. So, before venturing into endovascular therapy, one may consider which segment is involved because the patency rate and the approach will differ from segment to segment. So, task is divided these segments of the PAD to the aortoiliac segment, fibropopliteal segment, and the infrapopliteal segment. Coming to the aorto-occlusive disease, now there is a segment classification by Transatlantic Societal Consensus where we have divided the morphology of the lesion. For example, patients having the small stenosis, multiple stenosis, and the patients having a severe occlusive disease. As the type of lesion, the severity increases, the patency of the endovascular therapy may decrease. But this was the guideline which was given in 2007, and in last 10 years, so much development has happened. The task has issued a supplement in 2015, even advocating the endovascular therapy first in the task D lesion as well. So bypass will be effective in all these patients, but the patency rate of the endovascular may have some decrease if we increase the progression of the lesion. But now the recommendation is to have endovascular first approach because the less morbidity and less complex surgical revascularization. So let us have a look at the patients with aortoiliac stenting. Case of 55-year-old male with multiple risk factors had intermittent claudication of 100 meters. There was no symptoms of CLI, ABI in left was 0.7, right 0.9. And the patient has a life-limiting claudication which did not respond much to conservative line of management. So what do we see? We do a DSA. So patient has a symptom in the left side. So we take a right side axis so that if we can intervene, we can have a full view of the left lower limb arterial system of the DSA and see the inflow. So what we see here is a more than 90% stenosis in the left common iliac segment, and there are multiple, maybe 30 to 40% stenosis, tendon stenosis in the SFA. Below knee we see there is a disease, but there is still a single vessel runoff. Now, if this patient would have presented with a critical limb ischemia, would have a non-healing ulcer, then we would have considered revascularization of this segment as well as we would have done something here as well, depending on the site of the lesion. But because this patient has primarily come for the claudication, we will not touch this lesion. So this is the call one has to take on patient to patient basis, and one has to treat the symptoms rather than the images. So here we just went ahead and did a stent placement. So this was a balloon mounted stent placed precisely. The advantage of using a balloon mounted stent in this segmental stent, you can place them precisely over the ostium. So we didn't want to do anything because patient did not have symptom on the right side. We just placed the balloon mounted still, and patient had a good outcome. After that, there was elevation of the ABI and patient had improvement in symptoms. Another patient, 65-year-old male, heavy smoker, again severe claudication of 50 to 60 meter, ABI 0.7. Now in this case, so the approach to the endovascular therapy will also vary from the lesion morphology. So in last case, we saw the origin of the left common iliac artery was intact, so we could place a single stent. But in these kind of lesion, if I try to put a stent in the left, it will occlude or it will jail the right side of the common iliac artery. So what I have to do here is put a two stent. We have to put a kissing, or you can call it as a total endovascular aortoiliac reconstruction, where we have to put the stents in both the common iliac artery and do a kissing stenting in these kind of patients. Now this was a very unfortunate patient. I don't know. I mean, he did not have any vascular evaluation. Initially, he had a toe gangrene, got transmetatarsal amputation, then above ankle, then below knee amputation was done, but still the wound was not healing. And I was surprised to see that no one had evaluated him for underlying disease, even for the CT, and looked for the options of the revascularization. Patient kept on having the same problem: amputation, toe amputation, non-healing wound. Because he had a disease somewhere else, he had a proximal disease. We obviously did a CT angio, and then we took a patient for revascularization. Because the patient symptomatic was on the left side, we took a right lower limb angio. We can see there is a right stenostomy CIA, but more important, that patient has a complete occlusion of the left CIA and EI, extensive lesion. So obviously we planned the patient for the aortoiliac stenting, and then take the left side axis, crossed into the true lumen. One has to be diligent about crossing in all these regions, because when we have to confirm that we are always in the true lumen when we are in the aorta. In the last angio, when I saw, it was in the subintimal plane, then I had to take everything and try again. So always we have to take a check run to confirm that we are, because there are many cases people have stented to the false lumen to the true lumen with catastrophic consequences. So again, aortoiliac stenting was done, and patient obviously underwent a revision amputation, and this was the LV wound this time. So cause was lying somewhere above, irrespective of whatever amputation you do, it's not going to heal. So vascular evaluation is very necessary in all the patients having a CLI. Sometimes we may have to use brachial access for these kind of patients where we don't have enough space to put in a sheath into the ipsilateral common femoral. This was the patient we did from transbrachial side, and again did a check angio, was in the intimal plane, and this was the post angioplasty. It was a Padicon patient. Coming to the femoral-popliteal segment, this is a very challenging territory, and lot of development happened in last 10 to 15 years in this segment. Again, there is a classification for the task just to guide whether the endovascular surgery has to be done in these patients. More extensive and higher the grade of the lesion, less was the patency of the stents. But again, task D, like this lesion, more than 20 centimeter occlusion, triple aortic triperfusion lesions, surgery was suggested in 2007, but again now if one can do endovascular like atherectomy in these patients, it is desirable to do that. Rest all endovascular is considered to be the treatment of choice because of durable benefits. So this was a case of 65-year-old diabetic male with severe rest pain, qualifies for CLI, and we know whatever the lesion is that we have to treat because patient is already in critical ischemia. So this was a SFL lesion, maybe a task A or B lesion, so qualifies for the endovascular therapy. Usually we do angioplasty or DCB, but stenting may be required. For example, see, we do a angioplasty and then there are multiple dissections in this patient. So it was not a flow limiting. So in all these cases, one has to look at the angio runoff. So there were multiple dissections. I am here putting in a stent. One may say we can leave because it's not a flow limiting, but still we don't want this to close up and patient comes again for the intervention. So this was the post-stenting phase, and then patient is well. Now challenging artery is the infrapopliteal segment. I will see the angios. In this patient, we had a multiple level lesions. So in cases of CLI, one has to have a direct inline flow at least with a one artery. So if there is a disease in the SFA aorta artery, we have to do plasty of all the patients till the foot, at least one vessel should be supplying to the foot. Now it's easy to take a call till the popliteal because there is only a one vessel, but below the popliteal segment there are three vessels. So there was a concept of angiosome directed revascularization. We will see what is that. For example, in this patient there was multiple levels occlusions involving the distal SFA, popliteal, and there is a severe below knee disease as well. So we take an antegrade access in all these patients because we it's easier to cross all these CTOs. So there was a popliteal disease, and then if you see the runoff, there is a ATA. This patient had a wound on the heel. Though he had a single vessel runoff, but it was to the anterior segment and the angiosome. Basically, heel of the foot is usually supplied with the posterior, PT or peroneal. So we did a plasty and stenting of the distal SFA and then opened the peroneal artery. Now the challenges of the femoropopliteal segment are because of the extreme mobility of these segments, because which they predisposes this segment to the torsion, contraction, and a lot of forces. That's why the stents which we placed did not have much of the patency, but with the evolution there have been a development of the vasculomimetic stents where they are resistant to all these forces and show superior patency to the normal stents. Infrapopliteal segment, again there is a classification and the same goes task, surgical, and then endovascular, but now the endovascular first is preferred. Infrapopliteal segment is a tricky one because the patency rates are not as good as the suprapopliteal, infra and aortoiliac segments. However, the purpose here is not to have a patency. The purpose in infrapopliteal segment is to allow the wound healing. So till the patient's wound is healing, then it is good, and even if we have a limited durability in these settings. So what is angiosome? So for example, when we do an infrapopliteal, there are three vessels. So how do you choose if you want a single vessel or not, which vessel you want to open up? So there was a concept of the angiosome, like we have dermatome, we have a blocks of the tissue supplied by the specific arterial system. So one has to, for example, if patient has an anterior wound, we have to make sure that if we can revascularize the anterior, that will be beneficial to the patient. If patient has a calcaneal or a round wound, we should try and revascularize the PTA segment. In this patient, he had a lesion on the lateral aspect of the heel. So we could not, ideally we could have done a PTA recanalization, but it was not possible because wire did not cross. So we at least did a double vessel runoff with a peroneal. Now coming to the post-intervention management, when we do a revascularization, it's not like that the patient is cured of the PAD. Now we have just allowed endovascular to take over and allow the wound healing, but still the patient will have to have an aggressive management of the risk factors, plus all the conservative line of management we were doing in all these patients has to be done first to decrease the reintervention rate and increase the patency of the interventions. So extensive awareness is needed among colleagues and practitioners regarding the PAD, and we should all work together to reduce the level of amputation and increase the quality of life. Teamwork is the key to reduce the main, that is major adverse sleep events and cardiovascular events in PAD. And revascularization is a treatment of choice for all the patients coming with higher Rutherford category, that is central ischemia. Post-intervention management of risk factors is very important, again to reduce the cardiovascular and limb adverse events. Thank you so much.
Thank you, Dr. Very beautiful lecture. And I'm a surgeon. My father was a radiologist, and I was a radiologist. I took surgery because I wanted to do all these things, and now we are taking physiotherapy from surgeons. Is there any vessel in the body they can't do repair?
You should have taken radiology there.
I am regretting. So is there any vessel in the limb where you should not do angioplasty? Because you have gone intramedullary also. Doing that also. 80% success rate.
people are doing the toe and digital angioplasty also now with the 1 and 1.5 mm balloon. So
it's a very open lecture. Any questions from the audience?
usually, ma'am, the thing is that I would say really a nice question and it has been a topic of debate. Only indication of doing an intraoperative stenting is a dissection. So if you have a dissection, you do a prolonged balloon inflation to heal that, and if it doesn't respond, then you may have to do a spot stenting. So it's not that you stent the whole segment, but you place a spot stenting. And there have been ongoing research and new stents are coming for below knee as well, drug-eluting stents, but they are not available in the market as of now. So in that segment, one has to do angioplasty or atherectomy followed by a drug-coated balloon, which is a higher patency rate. Definitely. So it's an angiosome direct transcorital angioplasty you can also do if you are not able to cross, you can cross a wire and then again snare and a tube. So we do transpedal access also, transcorital also. Nowadays transpedal is a very, you can just puncture, suppose you are, the challenges in BTK angioplasty is because there are long segment lesions. So difficult to cross these lesions. So whatever you can do, if you see a distant target, you can puncture that and go retrograde and do a retrograde angioplasty.
And while doing the angioplasties, what's the length of patients you can cross? Like earlier it was for 11 centimeters length you can cross and otherwise you have to go for a bypass surgery. So now what is the new procedure now?
Ma'am, I think endovascular first approach is what we have been following now. So if we can do, then see bypass can be considered even if you fail an endovascular attempt. So every attempt should be given with an endovascular approach, and we have done 20-25 centimeter plasties, and Dr. Virendra is doing a lot of work on atherectomies as well. So we will be discussing about the advances. So that is a good option, a pretty expensive option, but we don't have much experience. But the ideal is to do atherectomy plus a DCB. Thank you so much.
One more question. If there are multiple classifications in below knee vessel, then is the approach going to change or what can?
So these are very difficult lesions because even if you plastic them, they will immediately recoil and shut down. But now there are devices available like lithotripsy, so you can break the calcium and open them. So that is one thing. Then atherectomy you can try. So these are pretty expensive devices, but yeah, they have increases the portfolio of the patient who can benefit from endovascular therapies. Thank you so much.
Thank you, Dr. Is the Dr. Virendra on this
Thank you so much, sir, for such an eye-opening lecture. I would request our chairperson to please felicitate Professor Dr. Prashant Srivastava, sir, with a memento. Please, sir. I would also request Dr. Manohar Rathod, sir, to felicitate Dr. Achal Gupta, sir.
ठीक है सर, ठीक है हो रहा है चार्ज हो रहा है
I also request Dr. Manohar Rathod, sir, to please felicitate Dr. Uti Rathod, sir.
रस्तों की तरफ ही आ रहे हैं। हाँ 2 मिनट।
Head of Department and Organizing President for the conference, respected Professor Dr. Aksha Gupta Ma'am, Assistant Professor and Organizing Secretary Dr. Manohar Singh Rathore Sir, and respected guest speakers for lamp lighting. Please ma'am, please sir. Humbled to invite our chief guest and guest of honor, respected Dean and Superintendent, Professor Dr. R.K. Thakur sir, our special guest, Professor Dr. Puneet Rastogi sir, and Head of Department and Organizing President, Professor Dr. Aksha Gupta ma'am for the CME. I request ma'am and sir to kindly take their respective seats. Please ma'am. I've been honored to invite Head of Department and Organizing President, Professor Dr. Aksha Gupta ma'am, to present welcome speech. Thank you, Ashwarya. Good afternoon, everyone. Today, I would like to welcome our Dean and Superintendent Dr. R.K. Thakur sir as our chief guest.
special guest, Dr. Puneet Rastogi, Professor and Head of the Cardiology Department today. It is my heartiest pleasure to welcome all the eminent senior faculty members, all the radiologists of the town, Senior Radiologist Dr. Bhojwani sir, Dr. Parmat sir and Dr. Chaudhary sir, and all the surgeons today on this occasion of Padicon. Our speakers from outside Gwalior, Dr. Viren from Vedanta, Gurgaon, and Dr. Aman Kumar from AIMS Bhopal. It is a pleasure to welcome both of you from outside and Dr. Jaiswal sir also. But he is from Gwalior only, but he is one of the speakers. And listening to both the speakers from outside has been a great pleasure, and it has increased our horizon in the field of intervention radiology. Warm welcome to all the delegates from our college, from MGM Indore, from GNC Bhopal. I really appreciate your active participation in the event. Welcome once again. I would request Dr. Aksha Gupta ma'am to kindly welcome today's chief guest and guest of honor, Professor Dr. R.K. Bhagat sir, with a bouquet and a memento. Please. I also request Dr. Manoj Singh Rathore sir to kindly welcome today's special guest, Dr. Puneet Rastogi sir, with a bouquet and memento. I would now request our chief guest and guest of honor, respected Dean and Superintendent, Professor Dr. R.K. Bhagat sir, to say a few words on the occasion. Please, sir.
First of all, I would like to congratulate Department of Radiology for organizing a workshop on peripheral arterial disease. I welcome the guest speakers from different parts of the country as well from our own, Dr. Jaiswal, Dr. Rastogi sir, Dr. Dalmia. See, this is a new era. We are searching everything day by day, but still there is confusion. Lot of times I receive phone calls from some politicians, from the bureaucrats. Patient getting admitted in the neurosurgery department, and everybody is calling me, neurology mein bharti hai, calling me. I think same problem here. The patient is confusing whether he should go to the cardiologist or vascular surgeon or to the interventional radiologist. But I think better way just with this such kind of workshops, we should spread the information. So the general practitioner or general physician should send the patient at a particular place, so he or she should not lose the important time. So I think this will be starting of such kind of education programs. So again, I congratulate you all, and dear students, don't forget, journey start with the first step. So this is the journey, especially for PGs, and in your future, a lot of new things will come, and you will see lot of target missions are waiting for you. Thank you.
Thank you so much, sir. I take immense pleasure in welcoming a special guest professor, Dr. Puneet Rastogi, sir, to enlighten us with his words of wisdom. Please, sir.
Respected seniors, guest faculty from Vedanta and Institute, Radio Lloyd department has done a wonderful job organizing the first workshop, especially on interventional radiology. This is the first workshop in Gwalior since I have been educated in MP. Nobody has conducted an interventional workshop, and especially from a radiology department. Maximum we used to have was basically MRI or CT scan. Now, peripheral vascular disease was initially a domain of a surgeon. Whenever a person used to come, he will go as a non-healing ulcer to a surgeon, or will go as a claudication either to a neurosurgeon or to a neurologist because he is having pain. Now, as a postgraduate students of radiology, you should realize that most important to differentiate is only one thing: rather the patient to walk with the peripheral pulses do not subdue themselves or came down if you are dealing with a neurological classification. Now, once we have various vascular ultrasound modalities to see for whether there is blockage in the artery or not, Manohar has started doing a wonderful job. And in fact, when the first this cath lab, what we call the intervention, was installed in radiology, I was one of the partners to get into the system, and I signed it for basically this radiology machine. And I did some of the procedures because we were not having any lab in the department at that time. And now the circle has gone almost 3 cities. We have a lab in the cardiology department, and we have a very less functioning lab in the radiology department. And this 2 year surprise, in 2.5 years, we have done more than 10,000 procedures in our department, and we have 3 DM cardiology seats in our department. Now, another important issue what I want to talk to all the radiologists at this point is, whenever you see a non-healing ulcer, always get a ultrasound done to see what is the flow in which arteries. Now, the first problem is you have a lot of interventionists who have come from Vedanta, and you will agree is that once you have a long segment stenosis, whatever stent you put, they end up with the stenosis. And initially we started doing most of the peripheral, and we found it present with a lot of stenosis. When the artery size is more than 4.5 to 5, they do really well with the peripheral stent. When it goes down to more than 3.5, you go to the peripheral artery, the more you find with long segment, they are coming down with this stenosis. I don't know what are the results of the self-extending stent which you have recently started long segment. Aorta is doing very well. We are implanting aorta with very good results. But peripheral arteries, whatever case we have done, most of them have ended with stenosis. Long-term result you will be knowing well because we are dealing more with the peripheral arteries. But non-healing ulcers is a very important cause. Claudication is a very important cause. And I congratulate the radiology department that they have done a wonderful job to organizing it. This will give you an insight into type of presentation of the patient and how to go about the diagnosis and management. Thank you very much.
We are very grateful to you for allowing us to use the lab.
We welcome Padicon ex-professor and HOD, Dr. M.P. Gupta, sir. I humbly request Professor Dr. Akshara Gupta ma'am to welcome sir with a bouquet and memento. I also request Professor
Professor Dr. Thapa, Dean, Medical College, SP Dean of the Medical College, SP Medical College, Professor Ramani, and other colleagues, students. I am feeling honored to attend this PhD on peripheral arteriography. Actually, I am a radiologist for very old time when there was no ultrasound in radiology department. We were for many years having combined course of radiotherapy as well as radiodiagnostics. In 1990, I got first ultrasound installed in the department because the publication of a free radiodiagnostics was pending for long time. And many people sitting here might be my students, Dr. Pulvani Mr. Anyway, but I will not take the time. I am being delighted to you, and I pray for success of this evening and for.
Thank you so much, sir, for gracing this occasion with your presence. Now it's time for floral welcome of our respected guest speakers, for which I would now request our chief guest and guest of honor, Professor Dr. R.K. Bhagat, sir. Our special guest, Professor Dr. Puneet Rastogi, sir. Head of Department and Organizing President, Professor Dr. Aksha Gupta, ma'am. Organizing Secretary, Dr. Manohar Rathore, sir, to please come forward and welcome our guest speakers. We welcome Dr. Viren Shorin, sir. I request Professor Dr. Puneet Rastogi, sir, to welcome Dr. Saurabh Jaiswal, sir, Dr. Aman Kumar, sir. We welcome Dr. Saurabh Jaiswal, sir. We welcome Professor Dr. Prashant Srivastava, sir, Head, Department of Surgery. We welcome Dr. Manisha Singh, ma'am. Ma'am is we also welcome Dr. Manohar Rathore, sir. We also welcome Dr. Rajesh Prajapati, sir.
Sir is not here.
Sir is not here. Now continuing with the next lecture on an overview of recent advances in endovascular management of peripheral arterial disease.
Dr. Daglia sir. Dr. Daglia sir. अंजलि जलेज में डॉक्टर डालमिया
ठीक अंजलि जलेज मैम आ गई और डालमिया उनको चेयर में बुलाना
I will now request
अंजलि
I will now request Professor Dr. Puneet Rastogi, sir, Dr. Anjali Jalaj, ma'am, and Dr. Ravi Dalmia, sir, to please steer the session forward. Please, sir, please, ma'am.
और सुनो प्रशांत सर डॉक्टर प्रशांत ला रही है हाँ सर और डॉक्टर
Dr. continuing with the next lecture on an overview of recent advances in endovascular management of peripheral arterial disease, for which I would like to invite Dr. Viren Shorin sir. Please sir.
Good afternoon, everybody. I will be speaking on advances in endovascular interventions or management for peripheral arterial disease and aortic disease. So this is our department. There is a division of peripheral vascular endovascular sciences at Vedanta. I am an intervention radiologist and there are vascular surgeons, so we work as a team. And coming to PAD revascularization, Dr. Aman has nicely given a lecture now that the aim of the treatment is to decrease the level of amputation or to improve claudication, quality of life. So that is the basically aim of revascularization and just not opening the artery. So this is how the clinical pictures which come to us. Being a tertiary care center, most of the patients are here and there and then they come present at a very later stage. And when you look at this, I mean, we feel really bad. Dr. Rastogi has already said that do a Doppler, you have a Doppler, there is a wound. So there is an arterial problem, we know, and the aim of your intervention should be healing of this ulcer and not just opening a vessel. So there are multi-level occlusions depending on the region you classify, task C, task D. So basically IEX, SFA, below knee, and there will be multi-level occlusions and you have to plan your treatment accordingly. I would say with open surgery, there were options, but with the endovascular, the horizon has increased. Surgery was really good, it still stands there, but I mean, there is a self-pop, you use vein, the patency is good, but nobody talks about this. There could be infection, graft infection, we do a lot of explants, the bypasses do occlude. The patients are really high risk nowadays with CAD increasing. A lot of patients are already on dual antiplatelets, ticagrelol. So the surgery has its own challenges, and hence there is a first the concept of endovascular first. So as of now, I would say the peripheral arterial disease has extrapolated a lot of their data from coronary interventions. Endovascular approach is basically a low risk, minimally invasive procedure, shorter procedural time, quick recovery compared to surgery, avoids general anesthesia in most of the cases. A repeat angioplasty can be easily performed if there is a restenosis occlusion. As I told, prosthetic grafts do carry risk of infection, and vein contours nowadays are not available most of the time, so it's not easy. So what are the advances? The advances are in terms of imaging, devices, techniques. So now you have an angiosuit which can be basically placed in a OT, and that's called as hybrid OT. So we are lucky to have one hybrid OT. The table is big enough, the room is big enough, the machine can go back. So it can be used as a operating room as well as an angiosuite. Here you can see in the images, you can take a pedal access, you can take a groin access, contralateral, you can take a brachial access. So all the imaging modality is available under one roof. So coming to pedal access, as I was talking nowadays, a lot of femoral, even iliac interventions we do through pedal access. So as the cardiology guys have already shifted to radial approach, most of the interventions now we can do through pedal access. If the patient has 2 or good 3-vessel runoff. If there is an occlusion in the popliteal, femoral, you can take an access, do a plastic stenting, and patient can go home on the same day. So nowadays the sheets are very slender sheets are available. So you can take an access, go retrogradely, and do your procedure. So that is a great benefit. Here you can see the wire has been retrogradely passed from below upwards, and then you can do your interventions into the sheet. It is snared out through the sheet, and then the rest of the intervention is done. So that's very handy. As my previous speaker has already spoken, we are doing interventions below the malleolar level, pedal access, digital access, so you can reconstruct the entire arch so that the vascularity is increased and there is healing of the wound. 1 mm balloons are available dedicatedly for the peripheral stenting, peripheral recanalization. So this was the question raised that most of the stents will occlude over time, and the reason is basically neointimal hyperplasia. So a lot of research is going on, it will go on. So we have good drugs available nowadays. There is dual pathway inhibitors, we have drug-coated balloons, we have drug-coated stents available for the peripheral arteries, and the primary patency is now close to 85% for a couple years. So this is how the neointimal hyperplasia happens, and the lumen goes down and it decreases. So the shape of the plaque to create a lumen basically, and then the concept is leave no metal behind. Once this is done, this is how there was an occlusion, so the wire was passed, atherectomy was done, so you can see the device moving across the popliteal artery, and then the flow was restored. You can do a drug-coated angioplasty, which has a good 70-75% patency for a year, and it can be repeated if it goes into occlusion. So this is again the pictures of the atherectomy, and this is the final angiogram. So complete occlusion, atherectomy followed by drug-coated balloon. So basically, what is a drug-coated balloon? A balloon which is having drug on it with a special ion, so that it is not delivered when you pass through the vessel or through the sheath. When the balloon is inflated, so there is a carrier, and this drug, which is sirolimus or paclitaxel, goes into the previously plastic or the vessel which you have prepared, and which basically decreases the neointimal hyperplasia. So the agents are paclitaxel. Now we do have sirolimus also available, and the concept is it gets transferred to the endoluminal surface, delivering a therapeutic paclitaxel which diffuses into the vessel wall, and then it decreases the neointimal hyperplasia. So now the another challenge was most of the long stents used to get fracture across the joint. SFA, also called as stupid femoral artery. A lot of stents used to fracture. Now we do have dedicated stents available for such arteries, which is called as vasculomimetic stents. So earlier the stents were laser cut stents. Now they are basically 6 nitinol wires which never break. So there is no fracture as of now reported for this stent. So they are really flexible. They follow the curves of the artery. You can see that image. Even after flexion, it looks great. So this is how the SFA behaves when you bend your knee, and you can see the stent on the other side of the image, which is basically a vasculomimetic stent, and it works well. Coming to another question which was raised, what about the calcium? So we do have, the cardiologists are using for coronary arteries. This is intravascular lithotripsy. So this concept is now available in the peripheral arterial. So whenever the artery is heavily calcified, what we do is we go in this intravascular lithotripsy, which delivers basically shock waves or lithotripsy to crack the calcium and increase the lumen of the vessel, and then a drug-coated balloon is used, and if there is a dissection, you can definitely do a spot stenting. So here it's an example of intravascular lithotripsy balloon, in which you can see it's widely opened up in spite of so much calcium seen across the lumen, which is seen along the wire. So here we can see a lithotripsy. Then again you can do this lithotripsy to the pedal axis. It goes through a 6 French sheet. And then you have IBUS or OCT is available nowadays. You see the OCT, how the lumen has increased after basically doing a lithotripsy or a plastic. There are a lot of devices available in the Western world which as of now don't have, but a lot of companies have registered for that, and I think in next 2 to 5 years we will see a lot of stuff. So there is front runner, there is a lot of re-entry devices available. So those are all latest advances in peripheral arterial disease. And as I told, we all are doing this work so that the wound should heal. Once the vascularity is restored, the job doesn't end there. You should have a good podiatrist, or you should be experienced enough to do a good debridement. Wound healing is itself an art. So this is how you can see once an angioplasty is done, it takes a lot of weeks to heal this wound, which were kind of non-healing for maybe months or years. So here again you can see on the right hand side, the intrapopliteal vessels were completely occluded, and once a angioplasty was done, AT and the critical arch was restored, you can see the wound starts healing with proper dressing and debridement. So there are multiple examples, and we get a lot of patients like this. So after vascularity has been increased, the wound heals, and you can prevent the level of amputation. Another bad foot, finally you could save at least the heel. So with proper planning, teamwork, state-of-the-art facilities, most wounds can heal. Coming to venous side, just want to show few slides that a lot of thrombectomy devices are also available. In our country, we have two main devices, which is angiojet and penumbra catheter. And there are few like Cleaner XT, which are adjuvant to these devices. In Western world, you have other devices like Trellis, Ecos. So there are many advancements happening on the venous side as well for treatment of deep vein thrombosis, mainly acute DVT. Now, regarding aorta, again, this has become kind of daycare surgery with a properly planned infrarenal aorta or a thoracic aneurysm or a dissection. If otherwise patient is stable, he can be sent home very next day. Where earlier there was an intra-abdominal aneurysm. This is what we used to do. So basically, it was aorto-biofemoral or a tube graft into the aorta, and it's a great surgery. It's a life-saving surgery, but again comes with its morbidity. Sometimes you have to do jump grafts to save mesenteric vessels. Now you have endografts available which go through 18 French, 16 French holes, and you can do it completely percutaneous. There is no need to even open the groin. So this is an example of one of the cases where only the skin was basically widened so that the device can go, and the closure device were used. All it needs is just to Tegadan dressings, and patient can be sent home very next day. So these are all advancements in endovascular intervention, and triple-A or infrarenal aortic aneurysm is a kind of daycare surgery, which is a reality. Coming to thoracoabdominal aneurysms, again, which was a big challenge. The thoracoabdominal incision used to be given a lot of blood transfusion, like 5-7 days of ICU stay. Now you can go ahead, make custom-made endograft, or it can be ordered, and then you match your CT scan images and make the holes accordingly, and then you have to realign and do fenestrations. This is an image of an IVUS. So once this is done, you can see beautifully both the renals, SMA, celiac has been cannulated and stent grafts have been placed, so you can avoid a major surgery, and the entire aortic aneurysm has been excluded, which was thoracoabdominal. Now coming to sometimes a lot of aneurysms and dissections, trauma, aortic transections post RTA comes, and then sometimes you'll have to jail the left subclavian artery because the dissection of the aneurysm is pretty close to the subclavian artery. So you can always do a small hole in your stent graft, align that hole with the subclavian artery, and then it can be aligned and cannulated, and you can save the subclavian artery. So this can be done. Earlier we used to do carotid subclavian bypass. Coming to, there are a lot of challenges, and you'll have more complex aneurysms. So the future is basically, I think, half or more than half has been achieved. Here you can see tower is already being done as a routine daycare cases nowadays. So you have percutaneous aortic valves, you have coronary stents, ascending endoluminal graft, you have multiple chimneys. In Western world, they have already started doing this, and then you have dedicated stenogram for subclavian artery, special stent for to correct the king. So this is the future. So the take-home message would be endovascular interventions has been drastic advancement with respect to available imaging modality, devices, techniques, and more so clinical outcome, and hence it has to stay. Vascular intervention has emerged from being mere angiography to a dedicated clinical specialty involving clinical evaluation, diagnosis, therapeutic interventions. And yes, it is not here to compete with any surgery, any modality, any specialty, but it will be always a companion for better outcomes, and it should be seen and welcome that way. Thank you.
मैडम का है ना
Thank you, Dr. Giri, for excellent talk, and I think you have covered almost everything from SMA down to BPL and all models. Your take on if the patient has got the restenosis, so what options do you have to treat that particularly?
So restenosis in a stent, right? Yeah. So sir, what we usually do is atherectomy is a great device. Once there is a restenosis, I mean, you will evaluate whether the patient is on proper medication or not. Sometimes most of our patients might have stopped their medication. So we go ahead, passing a wire through a stent is not a very tough job. You do some atherectomy, we place a distal filter, distal protection device so that there is no distal embolization. Once a clearing has been done, then we usually go with drug-coated balloon, or nowadays drug-coated stents are also available. So if there was a cause, if the patient has an accelerated neointimal hyperplasia, so we'll put something else so that that acceleration goes down.
Did you put the same drug-eluting stent or a different drug-eluting when you doing this stent?
Sir, we don't have, actually we only have paclitaxel available as of now. In the balloon we have sirolimus and paclitaxel.
We are using the same stent.
Yeah, so usually,
the basic problem what we are finding is that we have very rapid new atherosclerosis which is occurring with this drug-eluting stent. So once you have a restenosis, if you have a type of restenosis, you have to put a stent. Then it becomes very difficult even to pass a wire through that.
So you're talking about coronary or
peripheral also. So peripheral almost total block. I'm talking about the stent which is totally
So
blocked.
mostly what we are putting is non-drug-eluting stents now because it's a cheaper one. Okay. Drug-eluting stents as of now are, I mean, almost like 2 lakhs. So 1,70,000. So, and the longest length is 12 centimeters, so 120 mm. So, and those patients who have good insurance or those who can pay, we are putting drug-eluting stents. The normal stents, I mean, we can always go ahead, we still keep the concept of endo first. If we are not able to recanalize, then bypass is an option. Bypass is an option.
What experience with this drug-eluting stent, the chances of restenosis?
Sir, I mean, we have a data of now almost 2.5 years. One stent has got occluded, rest are all treated, but the question is, the longest one is only 12 centimeters. So we cannot compare with really long segment non-drug-eluting stents. So as of now, they are less than 15 centimeters, and the company is going to bring 15 centimeters in a month or so. So we don't have a head-to-head comparison. That's the challenge. In the Western world, they are saying the patency is almost 92% for 5 years. But again, the stent length is small, so we cannot say that it will
Continue with dual antiplatelet.
Sir, we do continue. We do continue in our patients, like coronary. There are no data now with the newer, this NOACs coming, rivaroxaban, with the study that Voyager and Compost lab which has come. So he has started using 2.5 milligram BD. Let's hope the results will be better than what we used to do, because clopidogrel resistance is high. And a lot of the patients who come with occlusions, we shift to ticagrelor. Yeah. So yeah, theoretically I would say yes. We have done not many, I would say, but close to 10 lithotripsies as of now. We have, because the literature says it does only eggshell cracking, and the chances of that calcium cracking and going down is pretty less. So case reports are very minimal. We haven't encountered any, but theoretically, yes, there is a chance. So if you are worried, you can always put a digital protection device like a spider FX and then do your lithotripsy because it goes over overnight wire.
Thank you. One more question.
Yes, sir.
If you compare the results of drug-eluting balloon as compared to drug-eluting stent in a case of these stenosis, so what would you like to do? You go for drug-eluting balloon or?
I would go with drug-eluting balloon. I have to recanalize or clean off my neonatal hyperplasia in the stent because I have good number of patients in which the stents got occluded and I had used drug-coated balloon and they are doing good. They are doing good. So it decreases the neonatal hyperplasia for sure.
Your reason is absolutely right. It is the debulking. The more debulking you get, the better it is.
And then your drug can penetrate nicely.
If more the debulking, the better it is.
Thank you.
Thank you so much, sir. We all definitely feel privileged today for so many informative sessions by eminent national faculties. I would now request Organizing Secretary Dr. Manohar Rathore sir to welcome Organizing President Professor and Head Dr. Aksha Gupta ma'am with the bouquet. Please, ma'am. This event would have never been possible without your support and guidance, ma'am. I would now request Assistant Professor Dr. Manohar Rathore sir to put forth his views on endovascular management of peripheral arterial disease in different clinical scenarios of hospital-based experience. I request our respected chairpersons to introduce sir.
Dr. Manohar, after completing his DMRD and DNB in needle diagnosis, has done fellowship in interventional radiology from Tata Memorial Hospital, Mumbai. He also holds European Board of Interventional Radiology degree. He is a currently assistant professor in the Department of Radiodiagnosis, CRMC Bombay, and in charge of interventional radiology in the radiodiagnosis department. Welcome to Dr. Manohar. Please give us his lecture.
Holds his fellowship in adult cardiac surgery from Finders Medical Center, Australia. He has worked over 10 years experience in cardiac surgery. Currently, he is senior consultant cardiac surgeon at VIMR, Kalyan and Parivar Hospital, Kolkata. So Dr. Saurabh will be speaking on the surgical aspect in favor of experts.
Very good afternoon. So first of all, I'd like to thank the Department of Radiodiagnosis for giving me this opportunity to stand here on this dais and share my experience, whatever little experience I have in peripheral artery disease interventions and bypasses. So I must admit, my experience is very much limited compared to the esteemed previous speakers we had here. So I would just like to share this with us. my experience is very much limited, and my forte is primarily arterial bypasses, and so I will try to stick to that. And I just rephrase my topics, and I will be talking in a nutshell about the surgical management of peripheral arterial disease. And throughout my topic, I would just like to I will just try to address all the issues which patients need an endovascular intervention, which patients will benefit from a surgical bypass. So first of all, as a vascular, we are not vascular surgeons. We are more of a vascular specialist. So we need to have a good physician skills so that we can recognize the ischemia. We can identify all the risk factors, and thereafter we need to have good intervention radiology skills so that we can stent all these, we can do the stenting and all these fancy jobs there. And thereafter we need to have good surgical skills as well, because there will be a small subset of patients which are not suitable for an endovascular intervention, and those patients would need a bypass procedure, a surgical bypass, or sometimes an acute kidney disease and endovascular. So here we are as vascular surgeons with our team in a continuous tug of war, and with an effort we are trying all the best we can, trying to clear them. So the presentations, as you already know, the patients present to us either asymptomatic or claudication, chronic ischemia, critical limb ischemia, or an acute limb ischemia. And this slide we have already discussed. I will just like to mention here is that majority of patients who are asymptomatic have claudications, they can be managed very well with risk factor modification and or medical management. There are a subset of patients who have got progression of symptoms from claudication, or they have got suspected severe proximal lesions. Those are the subset of patients which would need further evaluation in the form of an imaging study and followed by a revascularization, which would be endovascular or a surgical. So why all this is very important is because this chart shows us why. And when we look at the natural history of these patients, if a patient has a critical limb ischemia, so there is a very high risk of mortality and limb loss associated with these patients, and those patients who are either asymptomatic or have claudication. So these patients, almost around close to 10% will develop critical limb ischemia, and also in those patients subgroup, without intervention, they will have some form of amputation. So Rutherford came up with a very useful classification based on the symptoms and evaluation. So this is the classification for acute limb ischemia, and what we can see here is there is a viable limb but not immediately threatened. We can wait for intervention in these cases. And second group is a threatened limb, which is either marginal, where we can still buy some time, and immediately which needs immediate revascularization. And the third group is an irreversible tissue loss, and whatever we can do, we are not going to save this limb with any form of revascularization. This patient straight away goes for an amputation. This is the classification of chronic limb ischemia. So asymptomatics and mild claudications, they are categorized in the same group because the likelihood of progression is very slow in these patients. Then we have moderate to severe claudication patients.
कंप्यूटर लैंग्वेज में आ रहा है
Anyhow, I will just try to explain. Then moderate to severe claudication patients, they will do medical management, and if they progress or worsen, they will need surgical revascularization. So when we look at a group of patients who have got acute limb ischemia, so all these categories, except the category 3, who has got irreversible tissue loss, they all will need some form of revascularization. A chronic limb ischemia patient, if it's a candidate of revascularization, they will need imaging studies, either in the form of reflex or MRI or CT, and then as appropriate, they will need revascularization. Candidates who are not candidates for revascularization, they might need amputation, or if they are stable, they can be continued on medical management. So this Transatlantic Society Consensus document is a very important document, and the idea was, so many specialists from different specialties from many different countries and continents, they came together and they come up consensus document, and it covered every aspect of peripheral artery disease, right from the diagnosis, from imaging to the treatment, both medical and surgical. So the idea was to bring a uniformity in the management of these peripheral artery disease patients. So as already we have seen the previous slides and the previous presentations, they have basically divided lesions in two subgroups. One is the aortoileal lesions and the pseudopopliteal lesions. So type A and B lesions, they are more suitable for endovascular intervention. Type C lesions, if they are low risk, good surgical candidates, they can have a surgical intervention. Still, endovascular can be preferred as the first option in these cases. And type D, they are more suitable for surgical candidates. So A and B, as we can see, short lesions, short occlusions, and type C and D, they are more complex lesions and long segment lesions. Again, the femoropopliteal lesions, the similar classification, the similar recommendations, type A, B, C, and D. And here again, as you see the diagram, type A and B are short segment, short occlusions, and type C and D, they are long segment occlusions, severe heavily calcified vessels. And there are some cases who might be type C are some certain cases who have got recurrent stenosis or occlusion. Angiosome concept is a very important concept, and because the idea behind any vascular surgical intervention is not to see how well you have achieved a revascularization. The idea is to save the limb. So that is why the angiosome concept has come in. Primarily it came from the plastic surgery, plastic surgeons. So what they have divided the body into various angiosomes, and each angiosome is like basically it contains skin, subcutaneous tissue, fascia, muscles, and the bone, and it is supplied by its own artery and drained by its own vein. And so we know from these angiosomes that if a certain angiosome is showing ulceration or signs of ischemia, so you have to revascularize that particular segment. Then only you can have healing ulcer, or you can relieve the patient of ischemia. So the challenges we are facing are there are long occlusions, calcified vessels, infected patients, multiple comorbidities, and delayed presentations. The strategy is to correct the inflow first, then the outflow. The goal is to establish inline flow to the foot, at least in one of the angiosomes. And with this approach, with an open bypass, we can have more than 90% limb salvage rates, and even with sending almost the physical rates. And the most important thing is, goal is not primary patency. We have to treat the patient clinically. Goal is limb salvage. So in most of the patients, if endovascular intervention is achievable, we can try that first. And surgery is preferred for long occlusions, failed plasties, recurrent lesions, and heavier patients. Primary amputation again for non-reconstructible vessels, persistent infection and sepsis, and those who have got already have got paralysis and flexion contraction. Key steps include we need to have a good quality vein and graft, selection of good inflow and outflow, good antibiotic coverage, aggressive wound debridement, and post-operative care in the form of aggressive maximal medical therapy as well as adjuvant therapy in certain cases where the ulcer is not healing. So coming to acute limb ischemia, while we talk about all the fancy therapies which we are giving in the form of endovascular or even surgical bypasses, we must not forget the simplest, the most quickest, and the most effective way to treat an acute limb ischemia. Usually, it is due to an emboli, it could be cardiac or some other form. So initial period is the golden time, and if you do an intervention in this period, you can save the limb. So the simplest thing is mechanical Bugatti balloon catheter thromboembolectomy. You just need to expose the artery quickly. You need to pass Bugatti balloon catheters proximally and distally. You can establish the flow in these cases. In certain of these cases, they may develop reperfusion injury. And what is that? If a patient presents to you in a later, slightly late, so there will be some form of ischemia in various muscle groups, and when you revascularize this patient, there will be a lot of edema and there will be myonecrosis. So in some of these cases, you have to do empirical fasciotomy. You have to release those muscles group, give them some breathing space so that once you have revascularized, there are chances of limb salvage. So this is how you just open the artery, pass the balloon catheters. So this was a case of femoral. While it looks like long segment stenosis, but it was a long segment thrombus, and you pass the balloon catheters, and you have removed all the thrombus with good functional outcomes. Similarly, this was a traumatic case. There was a thrombus in the brachial artery case. So the difference between thrombus and embolism is just a slight difference. So a trauma, it will create a thrombosis of the artery, and it will damage the intima of the artery. So if you just do a embolectomy in these cases, it is not going to last. So what you have to do in these cases, if it's a short segment traumatic injury, you can do end-to-end anastomosis, resection and end-to-end anastomosis. Why? If it's a long segment traumatic injury, you need to resect that segment of the artery, and you need to have different conduits, like for an upper limb or an infrainguinal vessel damage. You venous grafts may perform better. Red surface vein grafts, and you need to organize that vein and make an end-to-end anastomosis. So these are a couple of cases where the limb was saved by using venous interposition grafts. This was the case. This is a longer bypass graft, and this is how the ultimate the patient comes on review. After 10 days, the limb is fully functional and viable. So coming to chronic limb ischemia, there are various bypass procedures available, and if they are categorized as anatomic, that means in line with the normal vascular system, and extra anatomic, there that means we are not following the normal anatomy when we are creating alternate different routes. So anatomic includes aortobiofemoral, aortoiliac, femoral-popliteal bypasses. Extra anatomic includes the femoral-femoral, crossover graft, the axillofemoral bypass, and thoracobiofemoral graft. So why we have categorized that the best long-term results are achieved with an anatomic bypass, because it gives you an inline flow. So extra anatomical bypass are reserved for patients who are sicker, who are older, have got multiple comorbidities. So you may not be able to do complex surgeries in these patients, and they are more suitable for an extra anatomical bypass. We have various choices of grafts available. The Dacron graft on the left, the PTFE graft on the right. The PTFE graft is also available as a ring graft also to prevent kinking. So in a nutshell, what we need to know is the prosthetic grafts are preferable. They can be used and preferable in suprainguinal bypasses and any infrainguinal lesions. Venous grafts are the preferred grafts. Only in those cases where venous grafts are not available, we need to proceed with the artificial graft. So like this patient had a very complex disease, complex aortoiliac disease with femoral-popliteal disease. The problem was again very diffuse calcified lesions. So patient needed an aortobiofemoral graft, and this is 3 months post aortobiofemoral graft, and all the limb is saved, good healing ulcer and good palpable pulses. So this is some of the surgical steps of an aortobiofemoral. We need to open the abdomen, we need to expose the aorta, encircle the aorta, we have to clamp the aorta and put in aortobiofemoral graft, and this is the groin incision wherein we connect these grafts to the femoral vessels. Sometimes, this is my personal preference. If the disease is very high, you are not able to get a very good segment of a supraciliac aorta, then you just open the thorax, put in the inflow from the thoracic aorta, take it to the hiatus and extraperitoneally, and do a thoracobiofemoral graft. These are certain examples of in this patient, like the vein was not available, so needed a prosthetic graft, and this is the iliac popliteal graft. And whenever veins are available, for all infrainguinal bypasses, we should use a vein. Like yes. So this patient was different. This patient needed. In some cases, we can even do bypass from the femoral to the tibial arteries also. So this patient had in the anterior tibial artery segment there was ischemia. So we put in a graft to the anterior artery and excellent long-term results. Just a pre-operative venous Doppler is very important to all these patients. Number one, you can exclude any deep venous thrombosis, and secondly, because you need to use a vein, so you need to be very sure that these are good quality veins. So the vein needs to be free of any thrombus. They need to be good size, more than 3.5 centimeters, and then only you use the vein. Otherwise, whatever, if you use a poor quality vein, the results are going to be poor. An example of external bypass, a very old patient, multiple comorbidities, can't stand a major operation. So you just open both the groins, take a graft from the, like in this case, we get a graft from the right femoral artery, flip it suprapically to the left femoral artery, and excellent long-term results. Again, a similar patient, sicker patient, axillofemoral bypass. So what is hybrid surgery? The concept is coming now. It's becoming more and more popular nowadays. So hybrid surgery is not like one thing. It's like you combine the best of two specialties. You get the best of intervention radiology, you get the best of surgery, and the idea is to give the best possible care to the patient. So, and sometimes it is also useful in the bail-out procedures as well. So this patient has a complex aortoiliac lesion. So what we can do, we can stent the aorta in the right common iliac and followed by a femoral-femoral crossover graft. So this is how we can best manage these patients with minimal morbidity and reducing the source of mortality as well. Looking at the patency rates of some of these bypasses. So, 5-year patency rates of aortophotic bifemoral bypasses with excellent, close to 80%. And femoral-popliteal bypasses, if you use a vein, so the 5-year patency is more than 80% nowadays. And with PTFE graft, the patency is in the range of 60-70%. Again, yes, for extra anatomic bypass, again, because we are not in line with the normal flow, the results ranges from 50 to 75%. And it is important. These are results from the older contemporary trials. Now we have various different agents, various different medical managements. We can put them on medical management, like they will be on warfarin, sometimes dual antiplatelets, and statins as well. So with all these therapies, the patency rates are improving. So to conclude, the peripheral artery disease carries significant morbidity in terms of limb loss and mortality. Early diagnosis and treatment are vital for good long-term outcomes. Surgical intervention in appropriately selected patients can significantly improve the quality of life and prevent limb loss. Thank you very much.
वहाँ से पहले शुरू होती है।
Thank you, Saurabh, for an excellent presentation. You almost covered everything. And yes, we know that there are some cases where the surgeons really come to save the life. When long segment disease is multiple blocks, we need to have only the blocks which are required. Excellent presentation. Thank you very much.
ओपन करना
Thank you so much, sir, for the informative lecture. I would now request our respected chairpersons to kindly felicitate Dr. Saurabh Jaiswal, sir, with a memento. Please, sir.
हो गया
this lecture. And you were already introduced, but again I introduce you. Dr. Manohar, after completing his DMRD and DMP radio diagnosis, has done fellowship in interventional radiology from Tata Memorial Hospital, Mumbai. He also holds European Board of International Radiology degree. He is currently assistant professor in the Department of Radiodiagnosis, GM Border, and in charge of interventional radiology unit in the Department of Radiology Department. Please,
Thank you. Good afternoon to all. After two very good lectures by Dr. Vinesh Chaudhary and Dr. Anand Kumar, I would like to highlight cases which we have done in our department. So, my topic is endovascular management of PAD in different clinical scenarios, hospital-based experience. So, before that, I would like to share with you right about the intervention radiology. What is intervention radiology actually? So, it is a subspecialty of radiology where we use the minimally invasive procedures to treat the patient. Sometimes the procedure is diagnostic or sometimes it could be the therapeutic procedures. So what we use for the imaging as the amount of fluoroscopy, CT scan or MRI. So most of the procedures require less than 5 mm of incisions and 99% of the procedures we perform under local anesthesia. So most of the patients usually discharge on the same day or maybe within 20 or 24 hours. So some of the procedures are maybe life-saving or otherwise it improves the patient's quality of life. So I just go through the brief history of our intervention radiology. So this was the man behind the development of intervention radiology, Dr. Shyam Ivan Rajendra, who developed the Sandinga technique, which we commonly use in our general practice. Most of the clinicians, surgeons, and intervention radiologists, vascular surgeons, all are doing using these techniques to enter into the body. After that, Dr. Charles Rodriguez, who laid down the foundation of intervention radiology and developed he also recognized as the father of intervention radiology. He did the first angioplasty in 82-year-old lady who refused to go for amputation for the blood in gangrene. So this was the first person who developed the intervention radiology technique. And after that, he did a lot of interventions on embolizations and other therapeutic treatments. So other therapeutic procedures like embolizations were often used in 1970, including GI and gastrointestinal GI gastrointestinal interventions. By the mid of 1980, a wide array of therapeutic interventions and devices had been developed. Since then, intervention radiology is evolving continuously, and radiologists no more remain as a shadow figure, rather become a clinician who ready to handle clinical patients in the midnight. After that, I just start my cases. This is the important slide. Why we need to focus on the peripheral arterial disease. As the PAD affects more than 15% of the population in diabetic patients, and India has a 77.1 million diabetic patients right now. And conservatively, treatment for approximately 10 million, conservative treatment is produce more than 10 million patients on risk of developing severely ischemic stroke, and more than 40,000 legs amputated in India each year. So by early detection and management, about 85% of these limb regions salvaged. However, the handling the diabetic patient require multidisciplinary approach. So with this slide, I start my cases, which we have done in our department. I would like to thank our Dr. Rasuli sir, who always support us to and give us care to perform these kind of cases. So this was the first case which I done when I came in Gwalior. This is quite interesting case. This patient come to us with the common history of diabetes, hypertension, and he had the complaint of buttock claudication. He had been consulted to many neurologists and other physicians and surgeons for this complaint, and he had been treated for the neurological symptom, as a neurological symptom. Nobody was given attention for the peripheral vascular disease. He came
I thought patient may have some vascular abnormality as the patient is having the cardiac engine. I thoroughly examined the patient, the pulse was absent in the patient, distal pulse absent in the patient, and on color Doppler, there was very minimal flow seen in the common femoral artery, popliteal artery, and below-knee arteries. So I thought there must be some abnormality in the abdominal artery. However, the patient was obese, so I could not see the abdominal arteries on Doppler. So I planned for the CT angiography. So when I did the CT angiography, I found a near total occlusion of the short segment of common iliac artery. So and absent of the internal iliac artery. So he was a typical case of Levin syndrome, where the patient was not getting supply into the gutter because of the obliteration of the internal iliac artery and poor flow from the right common iliac artery. Because of this, patient developed the right vestibular atrophy and gutter atrophy. So after this, we took the patient for the angioplasty and SLT. So this was the straightforward case, as I could see the small connections of the vessels through a strict flow of contrast. So I did the plasty of this lesion, balloon plasty of this lesion. Then we placed the stent across the stenotic segment. There was significant improvement of flow seen after the procedure, and the patient symptoms revealed immediately, and this was the picture after 1.5 months of procedure. So the ulcer almost completely healed just by doing the plasty. Another case. So this is the second case. He was a 55-year-old patient, diabetic, chronic smoker, on irregular treatment. He presented to cardiology department. I got a call from cardiologist that the patient is having severe systemic changes in the foot, and critically he is developing critically ischemia. So I saw the patient. He had the gangrene in the red toe and second and third toe. I did the Doppler where I found severe stenosis in the right external iliac artery and very poor monolithic flow in the rest of the lower limb arteries. So I took the patient for the angioplasty. This was angiography. This was the stenotic area, which was more than 90%. So I did the ballooning, and then after ballooning, I placed the stent across the stenotic segment, and there was significant improvement of flow seen, and the wound of the patient is gangrenous changes is completely gone after amputation, and the rest of the tools we could preserve. This is the same patient come after 1 year for the left leg claudication. There was narrowing in the external iliac artery and poor flow seen in the rest of the lower limb artery. So we did the plasty and the setting of the in the same patient on the left side also. So this was the picture. So we placed the stent across the stenotic segment, and very good flow seen after the stenting up to the toe. And the patient is immediately relieved on bed. You can see very good flow into the thigh vessels and below knee vessels and up to the foot. So this is another interesting case. This is a 61-year-old diabetic hypertensive patient on medical management. He had a small gangrenous ulcer, dry ulcer over the region. So he came to us in the OPD with the same complaint. We did the Doppler, and Doppler showed the monolithic flow in the common femoral, superficial femoral, and all the tibial arteries with the occlusion in the common area, so external iliac and common iliac artery. So on DSA angiography done somewhere else outside our department. So on DSA angiography you can see severe tight stenosis in the common iliac artery and significant narrowing of the external iliac artery. So we from the both side. We tried to cross the lesion from the ipsilateral side, from the affected side. However, my wire was going into the subintimal place into the aorta. So I stopped here, then I took my wire from the contralateral side, I mean from the right side. I placed the wire into the seat. You can see the wire coming into the seat here, and then I did the plastic on the left side. And after plastic and stenting, there is significant improvement of the flow field. You can see the good flow into the up to the tibial artery, and this is the stent flow. I did the balloon mounted stent as we need to precisely place the stent near the osseous area. The patient ulcer is healed completely in 6 months, and I did the doctor next day only, and I found the diabetic flow on doctor. So this is another case of angioplasty, 49-year-old male patient. This is also then he developed multiple gangrene in the leg and foot region. So I got called from cardiology department, and I did the doctor. I found the poor flow in the in the external idea, common idea, SFA, and all the tibial vessels. And I did the angiography to plan the procedure. On angiography, there was a bilateral severe total occlusion lesion. On the right side, there was calcified lesion with a complete occlusion of the common artery, and on the left side, there was a long segment occlusion of external artery. It was around 8 to 10 centimeter lesion. So I took the patient for the angioplasty. I took the radial X-ray also to see the control run, and then I took the puncture into the left common femoral artery, where I tried to pass the wire, and fortunately I could cross the lesion from the same side. Then I did the plastic. This is my wire across the lesion. Then I did the plastic of entire occluded segment. Though there was some stenotic segment, I found the stenosis because of the calcified plaque. So I stented the whole segment. So this is the post-stenting flow in the external iliac artery, and this is in the common femoral SFA and tibial vessels. So I'm surprised this patient came to me in the OPD again after 1.5 months, and you can see the complete recovery of the gangrenous lesions. Almost all the lesions healed up. So today we are also planning to take this case for the right side common iliac angioplasty. So this patient is admitted in the cardiology department, and we will take this patient for live workshop. This is another case. Now I am shifting to the SFA plastic. So this patient came. This is a female patient, chronic smoker from the village area, and post amputated. She had a gangrene in the grade 2. Amputation was done, but gangrene was not healed up. Then patient sent to us for the intervention, and she came during the COVID time. So we had a limited hardware. I did the angiography in my department only. Our department calculation is not very good, but again still we did the angioplasty of this patient, and the patient was having the severe pain and non-healing ulcer. So I found the milling of the SFA, long segment of SFA. We did the balloon angioplasty. We did not place the stent in this season because I achieved a good flow on balloon angioplasty. So you can see the flow up to the foot. So after plasty, in few months, the patient wound is almost completely healed. This is another case of SFA angioplasty. He is a 61-year-old chronic smoker patient, hypertensive diabetes, mellitus, uncontrolled diabetes, and CAD patient. He had a complaint of back pain as usual, and non-healing ulcer in the grade 2 and first and fifth row. Color doctor showed poor flow in the distal vessel, poor flow in the tibial vessel and chronic occlusion of the distal vessel bed. So I took the patient for the angiography and angioplasty. You can see there is total occlusion for a long segment of the SFA. There is correlated reconstitution of the vessel chain here in the lower part of the SFA. So we crossed the lesion by Pelamo wire only, and we did the we took the run from the after crossing the lesion to see the flow in the tibial vessels and the tuber bone. So after this, we did the balloon angioplasty of the occluded segment, and we as the flow was not very good after plasty. So I decided to place the stent in this patient. So you can see the stent. We place the stent across the occluded segment. Flow into the vessel. So we did the balloon angioplasty for this patient, and after balloon angioplasty, we achieved good flow into the SFA across the stenotic segment, and very good flow into the very good flow breath. So color of the
Line puncture, if there is not enough time given for compression, if the patient is on full dose of anticoagulant or dual antiplatelets. So it's a case just done yesterday, so I thought I'll connect it. So there was a pseudoaneurysm. Patient came after PTCA. Nowadays, most of the cardiology guys are also used to read the radial, and the art of femoral puncture is going, I would say, or they are being attempted less, and then again in a high volume center, the operator doesn't do a compression and he mostly to the nursing staff or their balloon. This is for the propellant. So it was a line puncture. It's a lateral or an oblique view of an ultrasound in a longitudinal case. So it was a surrender from the propellant. So I mean, the treatment is simple. You go ahead, take a thin needle, long enough to reach there. You can take a spinal needle, take Drumming or diesel, whichever company you want to use. Usually, if the neck is narrow, as I have shown here, Drumming works very well. So you go ahead, and here you can see we have entered the sac. The needle is going, and you can see the needle is placed pretty close to the neck, and then we are injecting the Drumming. That's the tip of the needle, pretty close to the neck, and it's so instant that while injecting you can see there is complete thrombosis, and this is the final picture. So this is propellant, and this is the arrow. So that's the neck. So this is the neck, and that's completely thrombosed pseudoaneurysm, and this is the SSP. So this is one of the commonest, and the treatment is very simple, I would say. So we have a protocol. If the pseudoaneurysm is 4 weeks old, it has properly epithelialized, then there is, I think it's a waste of time injecting a Drumming. The patient should be subjected to open surgery. Unless and until the skin is unhealthy, then he qualifies for a stent graft or something else. Otherwise, open surgery works very well if it is a chronic pseudoaneurysm. This is another case in which PTCA was done with Impala device. So it goes through a 14 thread sheet. They had used Angiosin along with Proglide, and patient comes back in 3 months with claudication. He is 70 years old. Complete occlusion of the access segment. So maybe patient had a, I would say, reaction to the footplate of the angiosin, or exactly what happened during the procedure, difficult to say. So this is how it was she was pretty obese, on lower antiplatelet, on Relianta. So even we didn't wanted to basically open. We went ahead and we continued in retrograde and we were able to cross the lesion. And finally we stented it with a vasomagnetic stent. There is still a bulge there. She's on follow-up, but 71 years old with multiple comorbidities, so we gave the best try. So this is one of the complications access-related that can happen. Other, as I told, sometimes your device can go bad. Usually it doesn't happen, but when it happens, I mean, you should have your stuff to take it out. So this fell down and went into the popliteal trifurcation, and then finally we could snare it with a 5 mm snare and it came out. So this is another thing which can happen, and this is how it was. So this is another, when you are putting a sheet, I just made this presentation while sitting here because I didn't know I had this talk. So this is an example, this is a carotid in which coiling was planned and then a sheet was played, and that sheet called dissection, and then there was a flap which could be easily served using that Pinamara catheter using a CAT-8 device. So this is something which can happen hypogenically during the procedure or complication of an endovascular procedure and can be managed. There was always a poly SFA-plasty was done and the lesion, and then there was structure and placing the stent graft. So I will conclude my talk by saying complications are bound to happen if you are working. Management of such complications should be found. Rule number 1 is don't panic. There is always a solution. Keep your angio suite catheter equipped with at least 10 grafts, layer, suction, thrombectomy devices, etc., which may be handy at such situations. And if not, and if you need an extra idea or something, always call your colleague, friend, senior, junior, never try to do that. Thank you.
You are regular in lecture, a total talk. Very difficult. Very difficult. I appreciate it. Very good cases you are presenting. And it is true. There is nobody who says that you have not performed a complication. It means you are not doing the cases. If you do the cases, complications are bound to occur. The more you do, the more complications you do. So every day is due for intervention. Thank you very much.
Thank you once again, sir, for the load of knowledge that you shared with us today. Now it's the time for the final talk of this event, and for this, I take this opportunity to invite on stage Dr. Manisha Singh ma'am to discuss this very important topic of management of diabetic ischemic lower limb bone or ulcers. I also request respected chairpersons to please introduce us to ma'am.
Respected all and my dear colleagues, it's a proud privilege for me to present here the real last session but very important. I'm to introduce Dr. Manisha. She is working as an associate professor in the Department of Surgery, GR Medical College, Gwalior. She is also a consultant diabetic limb salvage surgeon at Gwalior Diabetes and Nutrition Center. She holds fellowship in diabetic foot surgery and is also a fellow member of FIAGES. She has presented several award-winning papers in various national as well as international conferences. I am really proud and privileged to give so much what not is also being spoken here in front of you for your kind consideration. Very warm welcome to Dr. Manisha. Please present. Thank you.
Thank you, ma'am, for the invite. It's a pleasure to be here at Padicon this year. And I thank the members organizing committee, specifically Dr. Manohar or Dr. Akshar for having me here. And even Dr. Manohar has been continuously contacting me for the same thing. And he has also actually revolutionized the scenario at Gwalior, where it was a dream for us to have daily intervention. And for my ischemic diabetic process. So I just present my series, and most of the topics have been covered already in the morning by the eminent speakers. So my task is simplified, so I'll focus on my series and my problems when I'm handling diabetic foot patients. So WHO and IWGDF, they say that diabetic foot, which is the intramellular affection of the teeth with ulceration, infection, destruction, and varying amount of peripheral disease along with neuropathy. All these are the problems which are associated with long-standing diabetic foot. So in this era of the global pandemic of diabetes, there is a continuous rise of related diabetic complications, microvascular and macrovascular. Diabetic foot is one such complication, and it's a result of mainly neuropathy, cardiovascular disease with superadded infection. So these foot complications, the patient lands up with the hospitalization. Most of the times, up to 20% cases we get hospitalized. The commonest cause of hospitalization in diabetic foot patients is in diabetic patients is due to diabetic foot disease, and amputation is the most feared complication of the diabetic foot problems. And most of the looking at the stats, 40 to 70% of the all lower extremity amputations are on account of diabetes, and 85% of these are always preceded by a diabetic foot ulceration. So gangrene or non-healing ulcers, they are the cause of amputation 50 to 70% patients, whereas infection is only in the half of the patients. So these non-healing ulcers, when an ulcer fails to heal after 4 weeks of fails to shrink by 50% after 4 weeks of therapy, then we should look into the vascular cause or any other causes and the causes of non-healing. However, in the practice, we are first considering for the evaluation of the vasculopathy along with neuropathy. So in this study that they found that the diabetic foot diseases patients are very fragile, and foot ulcers and most of the times BP and PAD and other comorbidities are present which affect the general health of the patients. These patients are sick patients when they have an ulceration, and 5-year mortality rate is very higher than some cancers, and it's 25 to 60%. We have more of the neuropathic patients in our country, and compared to that, PAD is the scenario in most of the diabetic foot ulcers in developed countries. So whenever the patient has a diabetic foot ulcer, you must always think that multiple comorbidities are present, multi-organ disease, and the ulcer outcomes are going to be very severe, and with the intensive, which need intensive care, and especially a multidisciplinary treatment plan. So here we have one of our arms of multidisciplinary, that's the intervention radiologist, a very important member of the multidisciplinary team approach to a diabetic foot ulcer. So LVAD, that is lower extremity amputation, PAD, the diabetes is compounded by the presence of neuropathy, hence the patient does not feel the pain or the rest pain or any other ischemic pain, and is superadded infections are very common, relentless necrosis, a necrosis that doesn't stop, and then we should think that the ulcer has probably ischemia. So looking at the ulcer, we may not be able to judge. Even the fetal pulses may be palpable, still the ulcer may have ischemia, and the patient does not complain of pain, so we do not look into the various causes of infection. So prevention is the most important component. Prevent the first ulcer in a diabetic, then you can prevent the limb loss. So critical limb ischemia is advanced severe peripheral disease where the patient has pain in foot with tissue loss and gangrene. It is 3 times more frequent in a diabetic population compared to the non-diabetics. 50% of the diabetic ulcers have ischemia as the underlying cause. Arterial lesions are more diffuse, frequently bilateral, and they tend to involve arteries below 3 level. In patients with CLI, there are multiple arterial beds are involved, and the ulcer is more, they are ultra-distal. Sorry, the arterial lesions are more ultra-distal, and with the increase in the duration of the diabetes, there are more chances of having a vascular disease, and then the patient that having a diabetic foot ulcer is at high risk of having an amputation. So CLI is the most severe form of PAD, and present in only 1 to 2% of the PAD population. So whenever I'm told the features, so diabetics they are more predisposed, and we should look at the persistent recurring or ischemic rest pain, which may be slightly less in the diabetic patient. However, the ulcers have a disproportionate pain, or the pre-existing pain may be enhanced whenever there is ischemia in the limb. It's very difficult to do the dressing of such patients, and you should think that probably the ulcer is ischemic if there is disproportionate pain to the size of the ulcer. So ulceration of ganglion of the foot or toes may be there, ABI less than 0.4 and systolic antral pressures less than 50, toe pressures less than 30, flat pulse volume waveform, absent pedal pulses. So another complication of diabetic foot, that is Charcot neuroarthropathy, where there is it's a severely neuropathic, well-perfused foot with bounding pulses, and it can develop pre-ulceration, infection, hospitalization, and may suffer from amputation. In these patients, it's very incidence of PAD or arterial disease is very less, and need for respiration is also significantly less in patients with Charcot neuroarthropathy. So, when we compare the neuropathic with the ischemic ulcers, in this study they found that the revascularization failure rates were very high, end-stage renal diseases were higher, and also these were the independent predictors of major amputation or remote proximal amputation. Heart failure, number of comorbidities were also independent predictors of death, and whenever in ischemic ulcer, as we know, that's a multi-organ disease, so all these, there is very high mortality, and also the ulcer outcomes are worse. So there is poor rate of limb salvage in these patients compared to the neuropathic patients. So another study where the ischemic heel ulcers in the diabetic patients was considered. So it is said that heel never heals, and however the use of external fixators in diabetic foot surgeries with the proper offloading, the ulcers are made to heal. And in these patients, the heel ulcers are not infected, and the ulcers are well superficial. So these ulcers are more likely to heal with proper offloading. Revascularization failure, involvement of frontal arch, independent predictors of major amputation. So these are the, with a multidisciplinary approach, even a small ulcer, heel ulcer may heal even though it has really ischemic areas. And again, it has emphasized the role of using a multidisciplinary team. So another is the latest paper which has come is it again emphasizes that when it comes to revascularization, why we have talked since morning about the endovascular treatment, because it is the best and the first revascularization strategy, and it's almost completely replacing the need of bypass surgery, and it's also associated with the better amputation-free survival, and it is comparatively lesser deaths. So, discussing a case series, that is a 52-year-old diabetic patient with POVD developed red on diagonal on the right great toe, poorly palpable right ankle posterior tibial artery pulsations. Amputation of right great toe was done, and patient was sent for revascularization. So for this patient was admitted in the JH, and she had these problems. This was my first case with Manohar, and he assured that he was going to revascularize, and he did it, and you could see the distal receptive nerving in the color doctor, and then it was he did an angioplasty with monophasic velocity of flow, was seen in the popliteal and the tibial artery also. So the revascularization was done post that after 2 months the ulcer was found to be completely. So that's complete. So another case one was already discussed about this 53-year-old diabetic hypertensive CAD patients, where he did an external iliac artery and angioplasty. We've already shown this. So I switch over to another case. This is a doctor who showed triaphasic flow through velocity in the standing distal arteries. So another case is a 65-year-old female with diabetes, polyneuropathy, coronary artery disease, POVD with history of minor trauma to right for 2 months duration, blackening, ulceration, and pain for last 10 days. So this patient she had severe rest pain, and almost dressing was impossible to do dressings on her. And so we did it was found that her anti-TB and posterior both were deceased, and this was the CT showed diffuse atherosclerotic changes in the visualized red vessels, partial thrombosis of the bilateral common femoral and superficial femoral arteries and left popliteal artery, complete thrombosis of bilateral proximal and mid posterior tibial arteries, and distal and right anterior tibial arteries and right dorsal tibial arteries. So there was almost no flow, and this region was not available for tibial separation. However, as you can see, the segment is completely healed. So my husband is a diabetologist. He said when the main pathways or when the doors and windows are closed, there is something called a ventilator through which you get a perfusion, and you can see that this room has been completely destroyed of so much. It took 4.5 months to heal, and patient was always waiting at the dressing room, very difficult for me. I used to use local 10% liquid solution to dress her every time. It healed completely. So another 39-year-old male patient, he was a software engineer at Qatar. He came to me just because there were some blisters post hot water spilling over his feet, and he told me he has hypertension, and he also came out to be severely peripheral vascular disease patient. He had a heavy tobacco and cannabis abuse history, and once these blisters were removed, and I also looked at the pulses, did not bother much, and carelessly, looking at the age of the patient, the next time patient came with black toes in the same areas where I had healed them. Then I went for a vascular workup, did a color arterial workup, where it was found that there was almost no flow, and on the CT angio was done for the patient, PTA and peritoneal total occlusion was there, so below ankle we had nothing. PTA was seen at the angle, and we found that despite of all this, the patients who healed completely after ratio amputation and minor debridement and removal of the dead vein, so his wound healed completely. So this patient healed on medical treatment, on regular dressings, and removal of the dead tissues, and maintaining a good glucose balance. His blood pressure also controlled, is lost. From 108 kg, he is now running 82 kg. So another patient was a 75-year-old female DM type 2 with coronary artery disease with bilateral POVT. Recently, she came to me 1 month back, and she had POVT with right lower limb dry or wet gangrene, 2 to 3 toes, second and fifth toes with were also gangrenous, and there was right pleural effusion. So this patient was, when she came to me, she only presented with dusky toes, and there was a abscess at the base of the toes around the on the plantar surface. When I did that exploration of the cavity and I found the pus trapping there, so I had a doubt of ischemia, and the next day patient came, patient's toes were blackened, and they were questioning that the lesion looked more severe after intervention. So the patient, after going to the RDL doctor, it was found that the focus was in right distal ATA and causing altered hemostatic flow in the distal ATA and poorly detectable flow in the right PTA. Also, patient had chronic occlusion of right PTA up to the mid part with collateral reformation of distal PTA showing monophasic flow velocity in distal part, and diffuse atherosclerosis in call calcification, which explains the status of the right lower limb, severely ischemic with CNI. And this patient went to Gangana for vascularization, and they have shown that they did an angioplasty and restored his circulation in the ATA, and this was also in mid PTA with reformation of distal PTA by the collateral, so they all restored his circulation, and now the patient's wound is in this status, and I have to remove one more toe. So it is healing, and I can see the pain-free conditions. So what I want to tell is that you have to really work on these patients. It's not that if the revascularization was not successful, or immediately after revascularization you will start getting the right wound. It's not possible. You have to really work it day in and out, and you have to counsel the patient each time. So you can see that, and now I'm sure that the wound is also going to heal, which is much better. So another case was a 57-year-old male DM type 2 with peripheral vascular disease with coronary. The history of post nail driven trauma. So So it is the minor lesions in diabetic foot with the neuropathic background. These are usually missed and neglected, and they turn, when the disaster comes. So you can see after a nail removing how the bone infection spread in the forefoot and the midfoot. On the plantar aspect and on the dorsal aspect, you can see the gangrenous area as well. So this patient underwent a transtarsal amputation, and it is in this status now. And today he was supposed to get revascularized. The government asked him to do it in this conference. The patient cannot afford, but recently is probably having a cardiac event. His BP is 1 low in here, so you can't take it. But you can see that after debridements, the dorsal circulation is coming. It's the peroneal and congenital disease that we cannot see any good tissue to be contained in part. Spreading sepsis in the leg with psoriasis, and he's patient receiving continuous steroids for this. Probably that's why he became a diabetic. Long history of psoriasis. CAD with history of sudden onset pain and burning in the right foot toes for 15 days, followed by blackening of the toes in 4 days duration. So you can see the foot, and X-rays were good. So this patient, he has bilateral peripheral vascular disease, and we had to go for a right below knee amputation. This was done at Delhi, and it was not available to revascularization, and therefore has a ulcer and gangrene. So that also it's in a better state now. You can see that they are much better with regular dressings and debridement, and I am using L-arginine gel for this, apart from metrogel gel and the Debrides. So with regular slough cutting, control of sugars. This is another patient in whom the same history is there. The patient had wet gangrene of the fifth toe, and this color doctor was done, and there was a the posterior tubular artery and the anterior tubular artery both were found to be diseased. And you can see slowly the graduations are coming in the last picture. We have to remove the fifth toe, and I'm sure this patient also, and he is also not ready for revascularization. Asked him to come today. Today also is not ready. So then, what about those cases which are not available to revascularization, where the interventional radiologist said that we cannot do anything about these patients, because in our cases we do not have such, large circulation, restoration, or liver size catheters, and all these things are not available. These are patients not affording organs, even if they want to do it. So we go for a lumbar sympathectomy, vaccine. So in our hospital itself, we did the bilateral lumbar sympathectomy. In this case, I did with Dr. Rajesh Prajapati. And so bilateral lumbar sympathectomy, two separate joint incision was done. And you can see the sympathetic chain, and the patient had healing of the wound and the relief in the rest pain. So another technique since 2015 again, Rajesh is doing this omental transposition in chronic limb ischemia, and this was also end-stage limb salvage, end-stage ischemia for limb salvage. We did the omental transposition, and it is we know that it is not the microvascular stenosis, but bringing the omentum down to the leg from the to the substance thoroughly, and exploring the abdomen, and doing the same stage bilateral lumbar sympathectomy. This technique was started in 2015 by Dr. Rajesh, and I was with him, and we have done so many omental transposition, and we have got up to 70 to 80% success in these cases. So sympathectomy is, how does it act? So we do a bilateral sympathectomy because of the crossing over the two fibers. It has a vasodilator effect which are already there in diabetic because of the autosympathectomy. But however, it improves the collateral circulation, and the local blood flow is improved. And as a result, the gangrenous part or the stump, or which if you have removed the gangrenous part, that part can heal. So this is another case of Rogers disease with GM type 2 and chronic release smoker for last 30 years with rest pain. You can see the limb, and you can see the two ulcerated areas at the heel and at the great toe, dry gangrene for a few months duration. So for him also, although there was no foot circulation and bilateral lumbar sympathectomy with the vaccine was done. There was extensive thrombosis, so this circulation in the foot was missing. So you can see the tendering, and this is how it is done. Every 20 seconds the limb is lost to diabetes. We know when nothing works, we have to go and amputate. So amputation should be, it can be intrafoot amputation or the partial amputation where the knee is remaining and the weighted amputation is also less, 5-year survival rate is better, and amputation should not be thought of as a destructive procedure. It should be viewed as a reconstructive procedure if you have a better functional system constructed. So, and we have better prosthesis these days. So, proximal salvage which has reduced, proximal amputation which have reduced nowadays. So, there are certain adjunctive modalities, and it was found that Burgess exercise also have found to have a good effect on the foot peripheral circulation in patients with diabetic foot ulcers. Another study where TCPO2 was done in patients with neuroischemic diabetic foot ulcers treated with sucrose octasulfate dressings. So this pilot study was done, and it was found that along with standard of care practices, that is debridement dressings, all these cleansing of the wound was done, and sucrose octasulfate dressings were applied, and they found that it increases the TCPO2 and chances of healing. Another thing, adjunctive modalities, photobiomodulation plus adipose derived stem cells have been done on the type 2 diabetic rats, and it found that whether used alone or in combination, it does have a good effect on healing of the ischemic wounds. Another thing is hyperbaric oxygen therapy, much talked about for diabetic foot ulcers. Well, let me tell you that HPOT improves the major amputation rate. It reduces the chances of amputation, but not actually good wound healing. So, in patients with DFUs, EAOD with extensive infection, necrotizing fasciitis infection, recalcitrant osteomyelitis infection, necrose heel infections, you can see that under pressure the oxygen, molecular oxygen dissolves, and then it improves the perfusion, as well as it helps in wound healing by acting at the collagen laying down stage and at the inflammatory stage. So it is accepted as a standard active treatment, and much more larger trials are needed. Then we can see that in a diabetic foot ulcer with no option critical ischemia, no option, it's not non-option, it is a no option, which means that it cannot be treated. CLI which is not treated, which cannot be treated, it is found that these patients have more severe form of peripheral artery disease, they have more chances, more and more comorbidities, they have high revascularization failure rate, they have also distal arterial or the ultra distal lesions, and more arterial beds are involved, particularly below the knee, and they have worse outcomes in terms of increased chances of amputation and the mortality. So we can see that in these patients, they have higher amputation rates and higher mortality. Another thing is that in recent years, we have found that the increase in my practice also last 4 years, I am finding that the increase in the number of ischemic ulcers which are coming to the clinic, particularly in diabetic foot ulcers. Previously, there are more of neuropathic or the neuroischemic, but now the only ischemic component is also predominant. And the endovascular revascularization itself, a great hope is there, and patients with untreatable or the no CLI patients, we find that they are currently a clinical challenge for all clinicians involved in the treatment of ischemic diabetic foot ulcers. And failed or missing revascularization is further a predictor of non-healing amputation and mortality. So, future research is needed to improve revascularization techniques and outcomes. Even with the new techniques and new gadgets and equipments and newer techniques and well-trained interventional radiologists and cardiologists, still it is a challenge to the clinicians, vascular surgeons. Sometimes the patient is not responding, refusing the treatment, not fit to take the treatment. Then what should be done? So rate of major amputation still remains high, even though the techniques of endovascular surgery has expanded, even with bypass being possible. So why the amputation rates are still higher? So a deep insight in research into each characteristic of no CLI, that is which cannot be treated, is of vital importance to improve the further strategies and achieve healing and cure. To summarize, there is a rapid increase in the number of ischemic DFU. A high index of suspicion is a must while managing non-healing ulcers. As I told you, disproportionate pain is there when you are addressing them. Palpation of pedal pulses during clinical evaluation of such a patient and a color arterial Doppler study of lower limbs is essential. Prerequisite for managing an ischemic DFU. Presence of palpable pulses does not preclude proximal disease or proximal POVD. So even with palpable pulses, in a proper workup of the ulcer, especially if it's going into non-healing, we must go for a doctor. We should not defer it. A treatment delayed is a justice delayed is justice denied. So a treatment delayed is no treatment at all. architect of multidisciplinary team for managing diabetic conditions. It cannot be
Pankaj.
done alone. And
Pankaj.
such an approach is essential for limb salvage and may prevent amputation by 49 to 85%. Thank you for your patient hearing. So as I mentioned in my talk also, the bilateral lumbar symptom only improve the local blood flow, or also has a vasodilator effect in the local circulation. It does not make the pulse dilate if the pulses are wrong. So it has autoregulation of blood flow occurs, which is already there in the diabetes. Further adds up, and you can see the stamping. When it comes to adding of omega XC, what happens is that omega, it is a lipid component of the omega, which helps in the angiogenesis. Has been proven like that, and that's why we do the elongation of momentum. And even making the momentum up to the calf muscle or a distal ulcer, even that has a good effect. But this omega XC have a better effect in IgG. So we have found that when we were doing only lumbar only symptometry, the results will be better when we add the omega XC. We do not have the proper figures or the same now. We have done 2 cases from 2015, and I think Rajesh is in a better position to tell what difference we notice. Yes, because yes, ma'am, definitely it improves only post doctor state. The patient has come walking to us. One of the patients regularly thinking about OPD. He was crying and wailing and he could not walk up in the stair. After this procedure, it took some time and he was getting regularly he's coming to the OPD for follow-up. Even his doctor was done, and even though they found the increase in the blood flow.
In fact, I hereby thank you for this very good presentation. As a preventive person, since diabetes is becoming a hub, the most important thing lies in the prevention for this diabetic food and the cultural outcomes. When you have really quoted enough research articles to show the existence of all these things, it was an excellent presentation, and congratulations to you for being presenter in this way for this GR Medical College. Thank you so much. Thank you very much.
Thank you so much, ma'am, for the excellent lecture. I would now request our respective chairpersons to please felicitate Dr. Manisha Singh, ma'am, with a moment. Please, sir, please, ma'am. Aranya sir. Dr. Prashant Arya sir is not there. Thank you. So with this we come to the end of our seminar. I would like to thank all the respected speakers who shared their knowledge and words of wisdom with us today. Thank you all for those who participated for gracing this occasion with your presence. Now I would like to request our organizing secretary of this CME, Dr. Manohar Singh Rathod sir, to propose a vote of thanks for us. Please sir.
So it has been such an honor to be part of this wonderful event today, and I am glad to be standing here to express my vote of thanks on the behalf of entire organizing team. So first of all, I would like to thank our chief guest, respected Dr. Akshay Nigam sir, and guest of honor Dr. R.K. Zarbet sir, who allowed us and supported us to organize this event today. A very special thanks to our esteemed guest speakers, especially Dr. Giri Chaudhary sir, Dr. Anand Kumar, Dr. Saurabh Jaiswal sir, and all other speakers who accepted our invitation and being here with us today. Your deep knowledge into subject really inspired all of us. My sincere thanks to all various department, head of the department and of other consultants who spared their time to make this event memorable. I would like to thank our HOD Dr. Akshay Nigam who always encouraging us and guiding us to organize such a event. A wide round of applause and thanks to all committee participants and audio video team who made this event possible today. I would like to sincerely thank Cardiology Department, especially Rasoli sir, who allowed us to do the live workshop in their lab. And I also have thanks to all the cardiology technicians who is helping us to organize this workshop. I will be telling in my duty if I do not thank to my colleagues in all radiology department and all other students who made this day possible. So finally, I would like to thank all of you present here for spending your time to be with us and helping us to make this event a grand success. Thank you all.
टेलीकास्ट यही होगी
Everyone please proceed towards lunch. After this we will be having a live workshop which will be telecasted in this hall. Please proceed towards lunch. Thank you.
मशीन को प्रिपेयर करना है एक टेबल दे दे जस्ट पर ठीक है दो स्टैंड का पहले अपने को है ना वो वाला ले लो लाइव स्टार है वो वाला हाउस को खींच लो आज मेरे पास है हाँ डॉक्टर मन को लगाना ये करो
All can you all listen us? Can you hear us? Hello. Okay. वहाँ पे all doctors हैं ना? हाँ है. Okay. So we have taken the run from the left side. You can see the angiography source of left external iliac artery. ये focus करना. So you can see aorta, and there is cut off of the right common iliac artery from the origin, and the left side stent is well seen, and the flow in the stent is very good. So we have taken the catheter into the aorta, and we took the angiography from the right from the aorta, common iliac artery. Right common iliac artery is completely occluded from the origin, and the approximate length of the occlusion is around 6 to 8. And have to do the kissing angioplasty from the both sides. Let's start. Ultrasound के बाद दादा अभी आपकी पूरी लंच बनने ऊपर की है ना लाइट नापी नहीं किया वो तो चालू इधर को काम ग्लास दो किए वो समझ आ रही है क्या चला है तो दिख रहा है लेट गया लेकिन वो सीधे साइड में नहीं आ रही है सप्लाई बिल्कुल सीधी की सीधी साइड की नस बंद है तो अभी उसको भी बोलना पड़ेगी ठीक है आप लोग करके तो आप आराम से है
जेली डालते हैं ना जेली उसके ऊपर डालते हैं उसके ऊपर नहीं यार वो दे दे उसको पकड़
So now we will take the ultrasound guided puncture in the right common femoral artery. And there is a very poor artery under ultrasound guidance. Zoom in, maximum zoom in. ऊपर. लॉन्ग पेपर रखना है कल जो मंगाया था और 7 की बलून चाहिए पड़ेगी फ्लोर 6 का है इधर नीचे दिखाओ नीचे दिखाओ नीचे नीचे दिखाओ
फोकस नहीं हो रहा है इसको कहीं और कैमरा फोकस नहीं हो रहा है मतलब आप लोग आ रहे हैं सर बीच में तो कहीं और वो
इधर आ जाओ भाई पीछे आओ
सर आइए
यार ये बकेट थोड़ी पास में कर देगा
बेटा सामने अपने फिल्टर करना होता है थोड़ा हाइट पर कर लो
हटा दे वो मैंने यही सोचा था पहले दे देना
we have taken the run for
5,000.
So there is occlusion of the right external right common artery, distal part is seen. I have taken the run from the right common femoral artery sheath. चलो एक कैथेटर और ये कैथेटर में बाहर निकालता हूँ थोड़ा दिखाओ क्या है
नहीं क्रॉस तो एमपीए लगेगा ना
एमपीए
इससे तो वैसे तो इजीली हो जाएगा
एक H1 दे
वायर ही चली जाएगी H1 या थोड़ा सा बेटा इसको डिक्टेट कर दो नीचे रहना रेगुलर कहाँ जा रही है वो देखो इसको थोड़ा टेबल
इधर इधर दिखाओ so we are now preparing the catheter. This is H1 catheter. You can see the curve, this double curve catheter, H1 catheter, and we have taken the hydrophilic guide combination with catheter. उधर sheath का दिखाओ नीचे so we have placed sheath from the both sides. यहाँ पे तुम मशीन हटा दो
वो हटा दो
So this is in the left side, and now we are placing the catheter on the right common artery practice.
वायर आगे डालना चल so now we are trying to cross the lesion one second फ्री जा रहा है अगर सबटी में लेना तो पीछे डालो स्क्रीन इसको हटा के स्क्रीन थोड़ा पास में लेके आना सर हार्ड है अभी तो अगर सबटी में लग रहा है फ्री वायर नहीं
यहाँ पे ना एक दूसरा रोड इधर से रन लिखना भी है ना आगे पीछे हो थोड़ा फ्री जा रहा है कि नहीं होगी अगर नहीं जा रहा तो उसको अपन कैसेट को पुश करते हैं उसको रन दिखाना तो नहीं यार ये तो आगे पीछे होगा सब तो निकाल देना अगर ऐसा लग रहा है तो पीछे का उसको पूरा पीछे ठीक है नहीं तो क्या वो पैसेज बन जाएगा बार बार नहीं जाएगा लूप बना के ट्राई कर पीछे से नहीं ये नहीं है ये तो फ्री नहीं है नहीं अब ये लूप मत बना नीचे से लूप बना के जाए लूप उसमें ये अभी अंदर में लूप बना तो फिर और बड़ा जाएगा मैं क्या बोलूं भाई अगर तो नीचे से 70 मिल गया है और लूप बनाएगा तो 70 मिल नहीं रहेगा वो मैं समझ गया नीचे से ये तो ज्यादा मत करना वो पॉज ट्रैक बन जाएगा अंदर हाँ तो फिर पुश करना पुश कर नहीं कहते ना नहीं वायर को शुरू से ही सब ले लो उसको अब पीछे ले सकते इसमें रंग लेके स्टोर ही है ना इमेज है
ये सब
नहीं ऐसा कुछ नहीं है, 1 से 2 मिनट ट्राई करते नहीं सामान देना है, एक ग्लव्स देते 7.5। कोई लॉन्ग शीट है, अगर नहीं हुआ तो रेट्रोग्रेड के लिए लॉन्ग शीट है।
वो आइडिया वाला था। हाँ नहीं सर, वो आ जाना था।
नहीं, नीरो के नाम की तरह बीच में तो 770 कोई शीट नहीं है।
नहीं सर,
हाँ
नहीं सर, 790 वाली मिलेगी, लेकिन
टेबल नीचे लो ना, नीचे लो।
वाइड भी हो गया, चला गया
तो 790 चलेगी।
हाँ
मैं
7.6 वो 6 हो तो बल्ले बल्ले 6 होती नहीं जगह
6 नहीं है।
हाँ 5 ले लीजिए।
वो नहीं है,
सर वहीं से रख के कैथेटर नहीं हो सकता था क्रॉस लेफ्ट साइड से?
नहीं हो सकता ना, वही बोल रहे हैं, सिम लेने की कोशिश कर सकते हैं, शेयर कर लेंगे नीचे।
जी सर, जब तक
मैं बोलो ना उधर से
ट्राई करके
ट्राई करो
लेके आना, सिमन मंगवा लेना।
सिमन कैथेटर है ना वहाँ पर रखते हैं, मंगवा देंगे। ये सब रखो ना यहाँ लाके, सिमन कैथेटर रखो। सर आप निकल के देखते हैं बैच के लिए भी आपका मोमेंटो भी रखा हुआ है सर मेरे पास। हाँ जी, मैं भिजवा दूँगा सर। सर मुझे एक थोड़ी सी, जी सर थैंक यू सर, मुझे एक नीड है आपके पास, एक 790 वाली शीट रखिएगा ना, तो आपने यूज़ करिएगा हाँ नहीं 790 वाली सर, जो ऊपर जाती है, वो विनी बता रही थी 790
गाइडिंग दे दो,
कैलकुलेट जो किया था ना सर आपने। हाँ सर मैं भेज देता हूँ। हाँ सर आपके साथ मुझे मैं रख के डॉक्टर को बोल दूँ जी सर, थैंक यू सर। अपोलो तुमने देखा है ना? अपोलो देखा है ना? है ना? हाँ चलो चला जाए। मैं मोनू को बोलता हूँ, मैं गाड़ी में नहीं ड्राइव करें
जा रहे
कुछ भी
एक
केवल उधर लेना
और इधर लेना और ये है व्हीकल पे कुछ सिम आएगा पता नहीं
सर सीकर कैसे कर रहे हैं सपोर्ट कैसे कर उससे कोई फायदा नहीं है
और 6 की फिर शीट छोटी वाली ले लेना माइक्रो रेडियल वाली शीट ले लेना और पंचर वाली
हमें
लेफ्ट ही ना
अपोलो हॉस्पिटल चले जाओ मैं एक डॉक्टर सामान देंगे वो लेंगे
इसको थोड़ा पेंट करवा दे
हाँ पेंट करके नीचे डाल दे
हरी सिंह ये हाथ को थोड़ा सा हाँ ऐसे कर दे सुना ना तू इसको ऊपर कर ये रोटी कपड़ा और
अपना सर सीकर में का ये सगळं
सीक्रेट से मतलब ये है
सर
लाइफ
एक ट्रैक से ना
रेडियो शीट कौन बोल रहे
बेटा एक फ्री में दे देना हाँ
जल्दी जाने देख के ये विनीत है कौन सा
गाइडिंग दिखा दे
जल्दी लेके आ
100 वाला
अमित वो डॉक्टर भानु वाला के साथ चले जा ठीक है नहीं डॉक्टर भानु वाला आ रहे हैं एक और नीचे आ रहे हैं अभी वो दाढ़ी वाले हैं उनके साथ ये फोटो चल रही है ठीक है लोकल ले लो 15-20 मिनट में आ जाएगी सर
कोई नहीं जब तक गाइडिंग तो है ना शीट को लेते ही है
हाँ जी सर
शीट को लेते ही ये वायर नॉन एक्सटेंडेड है अपनी एक्सटेंडेड वायर लगेगी बड़ी
लेंथ है सर जबरदस्त
ठीक है जो लगेगी सबसे टर्मो ना
हाँ टेलीमोटर
बस ठीक है
एक सुख करने का इंजेक्शन दे रहा हूँ उधर, ठीक है
थोड़ा सा वैसे क्या है देखिए बाद में दे देंगे
सिवाया भी दे देना
हाँ सबसे पहले दे देंगे
ये मीटर एक सेकंड में और दे रहा हूँ अभी और दे देना मीटर इन वाला उसके साथ
सरकारी ये वो रहती है हाँ सर सरकार से आती है एक्सचेंज में करूँ देना
एक्सटेंशन लेंस करना
स्टेप लगेगा यार 11 नंबर नहीं है प्लेट
अभी नहीं है क्या नहीं वो थोड़ा चेक करना नहीं जाएगा हम लोग जाना था चला जाता वो अपने बचा मुझे तुमने ट्राई करके ना कुछ चला जाता वो गाइडिंग ले लो एक्शन में फिर वो ले लो ये गाइड की गिरे नहीं
अच्छा
वो रोएगा उस पर टू ही
उसमें 3 वो वाई कनेक्टर में लगाना पड़ेगा
वही डॉक्टर रोएगा तो एक काम कर पेपर 5 इंच होता ही नहीं है JR 5 इंच में लगवा है कुछ भी 5 इंच में डायग्नोस्टिक कुछ भी नहीं है ना तो इसके पीछे वो 2 ही या कुछ ले लेता है H1 है सर
वाई कनेक्टर देना पड़ेगा
हां है ये दोनों H1 डले हुए हैं
ये कोबरा
C1 है वाई कनेक्टर ले
इसको कंप्लीट करेगा पूरा ये ना अपन क्या करते हैं
वाई कनेक्टर ले लीजिए वाई कनेक्टर लेना पड़ेगा दे दे हां
लगा के अभी कौन सी पैर दी है नॉर्मल वाई कनेक्टर देना एक बार ये लगा दे तो ये
प्लस कर
प्लस कर दे इधर का ध्यान रखना मतलब वो ब्लॉक हो जाए हां सिम भी होगा बैठेगा सीआर पड़ा होता है लैपटॉप
हमारे को बोला था भेज देंगे तो वैसा
जीएमसी वाले दिन दिखा रहा है तुमसे
जैसे तो इसने क्या किया मंडे सर मैंने एक पेडिकन करना था वो भी नहीं कर पाया सर हम इतना स्ट्रगल भी फेस करते हैं
मैंने पूरे दिन देखा है बेटा एक शीट के साथ एक शीट दो लोग के सारी चीज के साथ वो चैनल पर डाल देते हैं बस ये वायर सामान मुझे 15 मिनट का केस है सामान नहीं तो नुकसान करेगा दिस इज नॉट आर्ट इसकी लोकेशन पे ये दिखाना केवल उधर दे दे अपनी तरफ दे दे फॉलो करना है इसको नहीं नीचे दे दे हां ऐसे और हाथ से फॉलो करना
सामने देना पड़ेगा हम तो नहीं
और हम बनती है और सुई बंद
हां बस
सर बंद ये फॉलो करो वायर को अंदर पर से थोड़ा हां वेरी गुड चलो चलो
फॉलो करो
केवल अपनी तरफ ले लो ऊपर ये जितना आता है उतना चलना
नहीं आप हां वर्टिकल
ऊपर नहीं जाता ऊपर नहीं साड़ी पे काम करेंगे सब बस रुक जा
वो उधर जाएगा उधर करना पड़ेगा
सर पेन भी मैं
सेटिंग
देखो चेंज होता है लिखा होगा ना वाइस आ जाना हार्ट तो दिखा दे अच्छा कोई ऊपर आ जाए वापस ठीक है चलिए वो कर दे 30 आगे डालने का
थोड़ा सा और अंदर डालना पड़ेगा
ऊपर ही दोस्त ऊपर ही ऊपर ही है चलना नीचे अरे इजी कर दे दो स्ट्रेट भी नहीं ना मेरे पास को स्ट्रेट नहीं है ना नहीं इसका बैक एंड दे दो क्या इसका देख रहा है इसी इसको निकाल दे ना स्ट्रेट नहीं है ना बस तो फिर से फिर जे बना के फेंकेगा मेरे पास देखा ये बाहर आ रही है शीट नहीं है नहीं ये ऊपर वाली इसको फ्लश कर दे खींच मत ये खींचने से आती है ये शीट को भी फ्लश कर दो इसको रख इसको फ्लश दे फ्लश दे पहले तो अच्छा हाँ इसके लिए भी दे मतलब सीरीज में दे प्लस ग्रीन अच्छा इसके अंदर से वो दे देगा स्पीकर दे गाइडिंग से चला जाएगा देना 4 फ्रेंच है 5 फ्रेंच है वो जाएगा जाएगा एक साइड पर सपोर्ट नहीं ऐसे पर दबा लो पीछे मत बता मैं छोड़ पकड़ा पकड़ा हां हां सर बता दो ज़्यादा करेगा तो फ्रेंच दिखा लो कितना में क्या है 5 फ्रेंच होना चाहिए 5 गाइडिंग से चला जाएगा कि 6 के चला जाएगा शीट से चला जाएगा रुक जा ऐसे नहीं जाएगा ऐसे नहीं जाएगा और क्या है माइक्रो जाता है ऐसे माइक्रो जाएगा ना वो तो 3 ये भी कौन करना पड़ेगा 1/4 की कोई वायर दे पूरा उल्टी वायर देना कोई खोलना तेरी लंबी एक्सटेंड लेंथ वायर खोल 1/4 की उसके अंदर भी कौन ले ले 1/4 के अपने कोरोनरी वायर है कोई मतलब नहीं है तो कोरोनरी लेने कोई भी ले ले मेरे को बैक गार्ड एक्सटेंड देना कोरोनरी का मैं खोल उसका बैक एंड इसको रोक दो आप लोग अगर देता तो ओवन 8 ऐसा भी लो 18 क्या हो गया कुछ तो सपोर्ट तो देगा हां ठीक है रोक daí 1 4 है ना, कोरोनरी वायर है ना।
हाँ।
कौन सी है?
ये 1.8 है ना, शुगर तो अच्छी है। लुईपोन इज 1.8 सर, लुईपोन इज 1.8।
कुछ तो है, वायर डाल दी थी।
हाँ डाल दी
पक्का।
बट पहले आप एडवांस डायरेक्ट स्टेटमेंट करोगे ना वायर का, अच्छा वो है ना
कुछ नहीं है, शीट पड़ी है ना, कुछ नहीं देगा ना, ये नहीं आएगा ना, कहाँ जाएगा वायर फिट कर दिया तुमने बस।
हाँ
आ गया वायर का
सब पकड़ लेते हैं।
ऊपर नहीं आएगा, वायर पकड़ के रखो। पकड़ के रख, पुश मत कर बस, क्योंकि पुश से ऊपर पकड़ होगा। बस आगे निकाल, गाइडिंग के अंदर चले जाओ।
पीछे लो
नहीं, ये इसे इसको भी पकड़ लो, दोनों चीजें, सी एक साइड को भी आगे
पीछे अंदर
सी कर को नहीं, अंदर नहीं, मतलब खींच के बाहर ले, थोड़ा सा सपोर्ट है, चोंच बाहर ले,
वायर ऊपर है सर,
बाहर निकाल, बाहर नहीं, मतलब बाहर गाइडिंग के बाहर
बाहर निकालो,
गाड़ी
आगे आगे डाल, हाँ यहाँ पकड़ दो, पकड़ के रख,
वायर ऊपर है,
वायर को ला रहा हूँ, पीछे नहीं है, अंदर कुछ।
फोकस करो,
बैक करेंगे
मूवमेंट ही है बस, ब्रैकेट तो ऐसी की तरह खराब ही होता है। हाँ रे, इतना कोई नहीं होना,
वही तो स्टिफ एंड ले रहे उसके बाद
टैगर है, टैगर इतना हार्ड कैसे कोई नहीं है। भाई इसको फ्लश देना है, सब कोई पूरा
एक प्लस चालू करना है, एक प्लस चालू करना है,
इसी से लगा देता हूँ।
डाई डालो इसमें,
हाँ बोलो उसमें से निकालना।
क्या तकलीफ है? बहुत कैल्शियम है, आपको कैल्शियम लगाना पड़ेगा।
इधर से बंद करो ना, तो पहले वहाँ से बंद करो। इससे ज्यादा मुझे लगता नहीं, सबसे ज्यादा सीडीओ वायर है ना ये सुगर एक्सट्रीम। हाँ बस बस
नॉर्मल के साथ नॉर्मल है, ट्राई कर लेते हैं।
चालू कर दो। कितना 300 है प्रेशर?
प्रेशर बढ़ाओ,
330 हाँ वो कंट्रोल दे रहा है। हाँ ऐसा बोल रहा है, कम कर देंगे थोड़ा सा बढ़ा। हाँ
के लिए थोड़ा सा नॉर्थ जंप है ना, पहले 0 था, ट्रैक थोड़ा बेटर हुआ है। यहाँ से मुड़ रहा ना, क्या करिए, जब हेडिंग धीरे धीरे इसी पे गया सिस्टम से, है ना, कितना कर दिया। उसके बाद करने है कि इसके 1/4 का पड़ा है, ये बनी लाया क्या? 1/4 से कैसे करें? नहीं है भी कौन? देखना कुछ सपोर्ट आ जाएगा, मजाक नहीं। ये देखना बिल्कुल ही कुछ नहीं मिल रहा ना।
CXI 14 नहीं है?
सपोर्ट ही नहीं है कुछ भी। मेरे को वायर
मेरी कार में वो पड़ा हुआ है सर।
क्या बोलो?
शुभम वो 14 रूबिकॉन लाया नहीं?
पकड़ के
हाँ अरे यार तुम लोगों के साथ ये सब प्रॉब्लम होती है। नहीं मिल रहा, ये नहीं हो रहा, बिल्कुल नहीं जा रहा।
तेरे पास बलून है?
हाँ सर।
1/4 का कुछ दे दे मुझे।
कोरोना बलून दे दो।
RX है मतलब मेरे को ऐसा चाहिए, इसको सपोर्ट देना है मुझे वायर को ना। हम काफी से लेके
कौन सा चाहिए?
एक बार मेरे को रन दे, ये शीट से रन नहीं, हमको इतना ही आना है 1.5 सेंटीमीटर। ये डाई है बड़ी क्या 50 रुपये है?
नहीं वो प्योर डाई है।
वो वाला ऑब्लिक दे, वो वाला हमारे पैर बचाना बस।
हेलो क्या हुआ बानो? हाँ तो तूने बात नहीं की सर से डरने सर? अभी लगा ना दोबारा से लगा डरने से तो फोन लगा। और उसको ना अमित को जल्दी 5 मिनट में नहीं मिलता तो वापस आ, है ना? 5-10 मिनट में डालमिया सर से बात कर। हाँ मैं बात करता हूँ। मेरा बैग भी उसमें चला गया, उसमें सर माइक्रो कैथेटर वगैरह सब है।
कौन से वाले?
कार में, मेरी कार में चला गया।
प्रोग्रेस टाइप हो रहा था?
हाँ प्रोग्रेस हो रहा था।
इतनी जगह भी अगर बना देना तो हम फिर हमारी
आपने सब खोल के रखा है
पूरा खुला था करते मैं तो डालते खुला जा ही नहीं रहा ना 1.4 का कोई। अरे तुम्हारे क्रॉसर वॉसर होते हैं ना 1.4 के, सीटीओ के लिए नहीं है क्या? एक भी नहीं है। नहीं वायर नहीं, सीटीओ कैथेटर होते हैं ना क्रॉसर के नाम से।
तो अपना रूबिकॉन लेते थे, तुमने फेंक दिया क्या रूबिकॉन?
सबको ले जा सकते हो। ऑक्स नहीं यूज करते? नहीं टोटल है। सरकार का नियम है क्या?
ऑक्स नहीं यूज करते?
थोड़ा ही साइज जो है। हाँ इसलिए रखते ही नहीं होंगे ना। देखिए ऐसे 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 करते रहो, हंसते रहो। और कौन सी कोई की बढ़िया वायर बता देंगे? इससे बढ़िया वायर है कोई?
क्या हुआ रूबिकॉन का?
ये ज़्यादा अच्छी है उससे।
अरे यार हम कोई काम की नहीं। तुम एक काम करो, गाड़ी से ना अपोलो हॉस्पिटल देखा है तुमने? देखा हुआ है? अपोलो चले जाओ, वहाँ से मेरे ड्राइवर को भेज दो वापस। मेरा उस भानु को क्या लिखा है ड्राइवर की, मेरे गाड़ी में मेरा वो है, जल्दी भेज दो।
जब तक देखते हैं
मैं इसको बोल रहा हूँ तो उसको भानु को लेके आना। मैं इसको बोल रहा हूँ वो वापस आएगा। ठीक है?
नीचे H1 था ना? नीचे जैसे पेपर 5 में कुछ H1 है ना?
वर्टिकल वगैरह
और एंगल दिया गया, करंट दिया, उसके 5 में होता ही। अपनी इंटरव्यू ले ले। वो टर्मो कौन सी हमारे पास में? तो
नीचे आ रहा है, इसको लेके चलते हैं।
क्या चल रहा है? क्या कह रहे हैं? आवाज नहीं जल्दी सो जाएंगे।
अमित तू वापस आया, मेरा बैग है तेरे पास। बैग के ऊपर
जाती होता है ऐसे करना मत कर। मैं पेपर आई नहीं जैसे जाकर ऐसे टाइम पे थोड़ी रखते हैं, कुछ नहीं रखना ऐसे बोलते जाने का टाइम बचता है।
सर 5 मिनट मेरा बैग आ रहा है, उसमें बहुत सब कुछ सामान है।
मुझ पर आके नहीं चले जाए नीचे से ऐसा नहीं कर गए नहीं अपना अंदर नहीं
नहीं लोग यहाँ से बन रहा हूँ, यहाँ से ना वहीं से जा नहीं रहा ना, तो
उसी जगह जा रहा है।
अच्छा सीटी है ना यहीं से, तो उसको जो लीज रजिस्ट्रेशन से वहीं जाएगा ना, वो अभी इधर से जाएगा। एक अंदर से जाता है, ये कौन सा
1 घंटा हो जाएगा करें ना 5,000
हाँ ठीक, पहले उस साइड से नहीं आ रहे, आपने स्टार्ट किया था।
नहीं दिया कहाँ था वो?
नहीं आपने तो दिया ना, आपको दिया था मैंने।
5,000 ही दिया है अभी तक।
तो रहना
आपने नहीं दिया होगा तो
तुमने दी थी वो 5,000 कभी नहीं दिया, उसने दे दिया होगा ऐसा बोला।
मुझे तो 5,000 ही पता है।
नहीं लेकिन बोला ना एक बार एक्सेस के लिए 3 दिया था, तो उसको पता है क्या था सामान देना, कार्ड दे दिया तो वेट नहीं मिला।
हाँ
इसका काम कर रहे हैं।
हरी सिंह जी ठीक है?
जब आपका घटना वो कहीं कैसे में उसमें वो हटाना पड़ रहा है, तार हमारे जा ही नहीं रहे होते।
तो उसके पास खड़ा किया है के ऊपर ही प्लेटफॉर्म है तो
ये लगा दे क्या?
नहीं वो नहीं है, ये देखना
रेडिएशन का बोला अभी अभी तो छोड़ देना, अभी तो नहीं चाहिए, अभी तो जब धक्का मारेंगे
सर टेरेन ये चलेगा अपना माइक्रो कैथेटर प्रोग्रेस?
नहीं प्रोग्रेस तो कैसे जाएगा?
वो वायर अपन तो ले सकते हैं ना उससे?
उसमें सपोर्ट नहीं रहेगा ना। तो सॉफ्टवेयर से लगता है यहाँ से यूज करना
कौन भी है मेरे पास
वायर को वायर वो टेलीफोन नहीं है टेलीफोन में जाता है थोड़ी स्टिक करना
ऊपर दिया लैंडिंग के साथ नथिंग एल्स थोड़ा सा इतनी आ गई इसके पास अभी 1418 का ट्रांजिशन हो गया, ये जाके राजी नहीं है। वायर ने तो काफी करके साथ दिया, ये नहीं साथ दे रहा ना, ये नहीं जाता ना, रूबीकॉन नहीं जाता ना, नहीं जाता ना, 18 है ना, 18 नहीं जाता। टाइटिंग का वो इतना चौड़ा है, शीट का वो क्या है ना, अच्छा इजी नो ये 5 फ्रेंच के से नहीं आएगा ना, रूबीकॉन थोड़ा भी आगे चला जाता है ना, जैसे राइटिंग इससे आगे तो मैं फिर इसका बैक एंड यूज कर देते हैं, खराब करते हैं वायर जान नहीं होती, पता नहीं बात नहीं, वैसे भी वायर नहीं सिटी वाली वायर में भी ग्लो वाली वायर होती है, बाकी में कुछ ना होगा और सब कुछ ही होता है। मेरा बैग भी उसमें रहेगा, अरे कुछ नहीं है पत्थर बनाने नहीं, पत्थर तो एक होता है, 3 चीज है बेटा निकाल करती है क्या? हाँ। कौन सी कंपनी की है? तोशिबा की है। तोशिबा मतलब क्या है? यार वो कहाँ है बाढ़ वाला बंदा? पत्नी का क्या नाम है उसका? पाटीदार
वो बाहर बैठे ऑन किया क्या?
गई तो है, लेकिन उसको ये बोल कि मेरे को सपोर्ट तो देना ही, गई भी तो क्या करेंगे, कुछ तो चाहिए होगा ना अंदर जाने के लिए। कौन सा बलून चाहिए आपको? कुछ भी फोटो प्रॉपर्टी में कुछ तो दे दो। उन्हें कॉलोनी चाहिए, बड़ा चाहिए नहीं, हर एक सिस्टम कुछ ओवर द वायर यार। सुनना दोस्त, 14 का लाया नहीं क्या तू सीकर? नहीं क्यों?
ये तो सीकर का तो मेरे को 3/6 बोला तूने, तो मुझे
बोलना थोड़ी देर स्मार्ट आदमी है तू।
कॉलोनरी बलून से यहाँ लगे हुए थे ना, देखो बलून का है ना,
रख लिया करना है, कैल्शियम करके हो रहा है।
डिब्बा लाओ, डिब्बा
मतलब यहाँ पे आप बलून जिसको रखते हैं
कुछ तो कोशिश कर सकते हैं, नहीं हो और सीनियर हो भी ठीक है,
ये इसमें देखो, ये बोलो एक नंबर से नीचे वाला
वायरस के बस में
एक नंबर से 5-6 फोन कंटिन्यू आ रहा है।
दूसरे देखो
एक नंबर
014 बना
5-4-5
014
हाँ
नहीं कोरोना की तेरे पास क्या है? पेरिफेरल क्या है?
पेरिफेरल का 2 mm
कर लेते ISC है
2.580
जिंदगी का सबसे बेकार बलून है यार ट्रैवल्स सबसे कम क्लास गाइडिंग से चला जाएगा
गाइड से जाएगा सही
नहीं गया ज्यादा चाहिए नहीं गया तो फिर कोरोना नहीं खोलेगा
तो चला जाता है
4
से भी
हाँ
वायर सर अभी आया नहीं आएगा तब
हाँ इधर से पुराना नहीं
फ्लश है ये लेकिन आगे पैटर्न होता है ना बाहर निकलता है
और करके देखिए वायर
नहीं गड़बड़ी बड़ी हुई है ये ट्रांजिशन बेकार हो गया ना ये
दो है ना
कोई नहीं आए तो बताना अभी आई नहीं आ गई
नहीं
अब आ गई
बस
पकड़ ली कुछ तो करते हैं इसको ना काम आया
वो ऑन कर देना कौन है हु इज देयर
मैं छोड़ना
बात करनी पड़ेगी तो पूछना पड़ेगा
कैन यू हियर मी सर बाहर बंदा बैठा है
उसे खुद ना वो YouTube देख रहा है क्या बोला पता है सबसे बड़ा लास्ट में जो हाइड्रोजन पार्ट है इसका नॉन हाइड्रोजन नहीं पकड़ लेना फिर सब वायर के साथ वापस आए पूरा पूरा नुकसान कर
अच्छा वो चिपक जाता है
बहुत ही थर्ड क्लास हो गई सिटी डिजाइन हो गए उनका सर अपना कुछ नहीं लगा के मतलब तुम्हारे लगा दे सब वायर भी लेके आता वापस चलो पकड़ना हाँ फिर वायर पिन कर देना अभी हम इंटरवल तक आए हैं लेकिन फॉल्स प्लेन में आए
नहीं कैल्सिफाइड टू क्रॉस हो गया ना
हाँ कैल्सिफाइड तो हो गया कैल्सिफाइड क्रॉस हो गया अब इसको ना अंदर ही बुलाना पड़ेगा ये छोड़िए ना वायर तो छोड़िए दोस्तों ये भी ध्यान से आप नहीं यहाँ से ये इंटरवल में आए फॉल्स थोड़े फिर नीचे से आएंगे इसको करेंगे ऐसा है बलून जोड़ो आधा गाड़ी में खुला
इंटरप्रेटर दे दो
हाँ
इससे छोटा नहीं था 80 सबसे छोटा था ना
हाँ तो फिर गाइडिंग में रिपीट हो जाएगा
हाँ देखते हैं कितनी होगी इंटरवल में गया हुआ है
हाँ हो सकता है गाइड आ जाए
हाँ पुला सब सिखा दे तुम्हें वहाँ पर GMC नाटक को देखा मैंने लड़की भोपाल से ले आया था
I did not expect.
हाँ एक्सपेक्टेड वाली चीजें
मेरा बैग आ गया सर बैग में नहीं था
कोई नहीं अभी तो करते हैं पहले इसको बुलाओ ना दोस्तों
कर दिया
ये नहीं बड़ा वाला रॉकिंग बैग
जोड़ रही है
ये रख दो वापस दे देना
अभी कुछ क्या कर रहे हो
रोल इन्फ्लेशन
हाँ
इन्फ्लेशन ये नहीं है ठीक है बिल्कुल ये भी कर दिया
आ गया हाँ
प्रोमो सेव करना है वो नहीं दिया तूने
2.5 ना कुछ
10 है 10 तो हो गया सर
14 14 दिखता नहीं पढ़ाई ना क्या दिखेगा
मैंने 20-22 में किया था,
ऐसे ही रखना, मैं गाइडेंस चढ़ा रहा हूँ, ठीक है। नहीं 20-22 में पढ़ गया ना तो फिर बन जाएगा 14-16 तक, ठीक है।
मैं तो कोरोना के
कोरोना नहीं कर सकता है,
20-22 तक भी नहीं कर सकता।
तो
थोड़ा सा
गाइडेंस चढ़ा हुआ है।
आगे गाइडिंग कंप्लीट हो गया
गाइडिंग पीछे ले रहा हूँ तो शीट पकड़, नहीं मुझे जाएगा नहीं, मुझे मालूम है गाइडिंग की तो अपना कोरोना हो गया था, अब डालो एक बार गाइडिंग डाल, नहीं जाना तो चल ऊपर कर लेना, डिफ्लेट कर, जैसे डिफ्लेट करेगा ना तो अंदर आ जाएगा, डिफ्लेट किया, चल डाल बस दोस्त बस गाइडिंग
नहीं सर गया थोड़ी
नहीं है पीछे नहीं करूँ भी काफी है यार, ऐसे तो
बट सब
चल खुला दूँ देखिए ना मतलब नेक्स्ट स्टेप तो बढ़ रहे हैं 14 का ये करना है
बट अभी खुल गई नीचे हो गया
मुझे लग रहा था
अच्छी चीज बोलते रहो तुम,
थोड़ा सा नीचे दिखा
नहीं यार ना मुझे दोस्त इंटरनेट चल रहा है, ठीक है ना। अब एक काम हो सकता है, गाइडिंग का ही रिव्यू करा के मैं कुछ कर दो ना तो मजा आ जाएगा। अब एक काम कर सकते हैं, इस वायर पे डायग्नोस्टिक वो क्या था 180 वाला सिस्टम देते हैं, 180 कोई वायर है देख तेरे पास सिस्टम क्या क्या
नहीं आप ये निकाल के बलून से बनने का
नीचे ऊपर से कुछ करके स्नेक ने करना ना, अब तो तेल ऐसा है ना 2 नंबर होगी ना, गर्मी पॉसिबल गर्मी पॉसिबल वही ना, वही मैं सोच रहा था कि भाई मेरा कुछ तो सिस्टम ऐसा आ जाए कि
सर ड्राई कैट स्टेट टेरिनो है सर,
रुक जाओ इंटरनल में आके शेयर कर देंगे, हो गया तो वायर तो नहीं ये वायर निकल, अब इतनी वायर निकले थे तो वायर उन्होंने घुसा भाई थोड़ा ऊपर लियो वायर और इसका ये कोई ब्लैडर कैथेटराइज नहीं है क्या कैथेटराइज नहीं है
क्या सर
कैथेटराइज नहीं है अंदर फ्लश दे
यहाँ से जाके और
इधर से
हाँ रूबिकॉन है ना
दोनों इंटरव्यू है ना अपन तरीका नहीं है
इसके अंदर अच्छा अंदर दबा कोई दिक्कत नहीं
ये ले इधर आ भाई इसको निकाल लो
कोई नहीं
तो सीसी किसी नहीं होती है दे दे
तो फिर बंद कर दो ना
चेक करवाने के बंद करवा
मैं बंद नहीं कर रहा,
मैं खुली नहीं बंद कर
ये डालिए
नहीं नॉर्मल
चल निकाल वायर निकाल, इसको गीली करके रख निकाल ले
फाइनली इंटरनल में आ गया सर।
तो वो अभी टिप कहाँ है
तो पुलिस भी बढ़ गई है, पुलिस जाना पड़ेगा,
डालो मैं कह रहा हूँ
पुलिस जाना पड़ेगा बोलो
वो टूटा है फ्लैट सिस्टम टूटा है अंदर जाके थोड़ा अंदर जाके
सिस्टम को लॉक पुलिस के लिए
सर सिस्टम ही डालूंगी डॉक्टर को डालूंगा
ठीक है वायर वापस नहीं गई टूटा दिया और डबल डेंसिटी के सारा
इंटरनल से
अब देखेंगे इधर से भी डालेंगे और उसको शेयर करके लाएंगे
ओह इस दिन नहीं है
शेयर बनाना पड़ेगा 140
वो वाला स्नेर इधर इतना छोटा बन जाएगा क्या सर लाइटिंग वाइटिंग डालना पड़ता है
एक काम करता हूँ फिर
वो 35 वाले से बना सकते हैं ना
एक बलून वायर एक करते हैं कुछ करते हैं वायर वायर वापस दे यही वाली वायर इसको ना यहीं बलून खुलाते हैं इंटरवल में और फिर देखते हैं
बड़ा बलून खुला देते हैं
और बड़ा इसका 1/4 में है ही नहीं ना हमारे पास शॉर्ट वीडियो
वो भी वो तोड़ेगा नहीं सर उसको क्योंकि वो क्या ऑस्टियम के परपेंडिकुलर रहेगा
बट व्हाट एल्स कैन बी डन यू टेल गाइडिंग को मैं आगे अगर ला सकता तो फिर मेरा काम हो गया रहता
नहीं
लाइटिंग वगैरह आप आगे लिया तो फिर उसके अंदर से उसकी
हाँ, फिर मैं इसको तोड़ के कैसे कैसे फ्लैट में कोशिश बेटर करना करने की कोई एक बुला दिया यार ओ भाई इसमें
यहाँ से अगर अपन नीचे से हम ट्राई करेंगे कि वायर
अभी डायरेक्ट कई बार इसको काम करके तो फ्लैट को उतार दे समझा क्या अपन इसको थोड़ा पीछे लेते कैसे चलिए मीटर में एक बार आई तो दोबारा भी जाएगी अब एक काम यहाँ से कर देते ट्राई दे वायर निकालना पड़ेगा नीचे से डिग्री है 70-60 कितना है ओब्लिक 20 है 21 है 21 है थोड़ा सा और कर दें थोड़ी सी और दे देंगे 30 है बस ठीक है चलो अब इधर से इधर लाना है अब इसको रोक ले बनाता उड़ना कुछ होता है कि तुम्हारे हाँ कर दिया
नहीं अब तो हो गया ना सर पीछे लेके अब सीधा आ गया है ना ये तो अच्छा
अब वो फ्लैश से करते करते इसमें आएंगे फ्लैश के थ्रू एक प्रॉपर लिख फिर भी वी कैन ट्राई ना एटलीस्ट वी कैन ट्राई नहीं आता है क्योंकि वो इस वन से आया है
कहां से ब्रेक हुआ है
नहीं लेकिन मेरा ये कहते हैं अंदर जाए तो शेयर करके ले आऊंगा बस ये नहीं रखता मनोहर अब मैं वो मैं लास्ट एक्चुअली 3 लाइन थी स्नेयर था उसमें
टेलीग्राम स्नेयर
भाई वो दिखाना ऐसा रोड मैप नहीं बनता वैसे होता है ये ना आइडिया से जाना पड़ता एक डॉट ही करते पेन का
सर उसको अच्छा ये लिया हुआ है ना
ये तो लिया इसने
मतलब यहाँ तो सुनना उसको अनसब्ट्रैक्ट हो जाएगा क्या उससे
कोई दोबारा चले जाएगा ये जस्ट है ये कोई कोशिश करेंगे नहीं तो फिर लास्ट ऑप्शन है वो होममेड स्नेयर बनाएंगे कई बार अपन अंदर की वॉल पकड़ के आए ना अपन
ये वॉल पकड़ के आए ना
अगर 3.5 का वायर होता तो मैं तोड़ के इधर आ जाता वो भी तो नहीं है ना
3.5 का
एक खोलना थोड़ा
3.5 का क्या चाहिए था
3.5 का सिस्टम नहीं आ पा रहा नीचे में अब खोला के आएगा पूरी मूवमेंट थी तो टिप को करेक्शन ये निकाल गीला कर हल्का सा होकी दे बिल्कुल उसकी सीधे हल्का सा होकी देंगे तो ब्रश करेंगे तो अंदर वो सारी साथ दे ये थोड़ी बहुत गीला निकालने के लिए जाते हैं बहुत नहीं करता देखा ये ना नीचे वो तो मुझे पता है वहाँ जाके तो नहीं वहाँ जाके तो हम आके वो कर सकते हैं कहाँ से दे दियो
सर कितना कर्व लेना है
थोड़ा सा हॉकी स्टिक से हॉकी खेल रहे नहीं गया तो फिर शीट भी नहीं मिली ना अपोलो वाली शीट नहीं मिली
वो सर देखे आना है वो एक्चुअली सर संडे भी
देना थोड़ा पेट को
तो बैठ जाने का
क्या हुआ
ये ऑन है
लाइव वाले को बोला था तो बैठ जा हो गया
आज कितने बजे 7 बजे
आपके कितने बजे
क्या आ गया फिर 7
आपने बोला था करते रहो फिर 5 बज जाएंगे, आज तो बज ही गए।
आरडीसी है छोटा है, 7.5 फ्रेंच 6 फ्रेंच का आरडीसी गाइडिंग, छोटा गाइडिंग क्या है 70 सेंटीमीटर में। हाँ 6 में ही 6 में नहीं गाइडिंग वो में डबल लूप आएगा कि नहीं आएगा वो इधर होना है गाइडिंग
ओवन बोर्ड का तो आ जाएगा ना,
टेबल बताएगा एक वायर पड़ी है ना
कोबरा कहते थे कहाँ वो कोबरा हमने निकाला था जो।
अरे वाह
चलो अब सेव कर लिया इसका जो भी करते हैं गाइडिंग को पकड़ लियो, कर लिया वो पिछला ही हुआ अब चलिए इसका स्टैंड तैयार कर लो। अब इसके अंदर डालेंगे पहले मैग मूव कर दे जितना करना है
मैग कर दे भाई, सेव करते जाना है भाई।
तू बार बार मत कर, यहाँ के भगवान भी नहीं पता मुझे तो।
आगे
अंदर नहीं एक भी कर मैच कर दे जितना कर सकता, कॉलीमेट कर दे,
मैच कर दे
और बिल्कुल कॉलीमेट कर दे। अभी ऊपर की लाइन बंद कर दे हमारी। कैथेटर है ना, ये भी दुखी करना ना, इसको जब भी तो दुखी करना, शीट में लाना है ना, कैथेटर को पूरी आई हुई है ना, तो आजा नीचे, शीट दिखती भी नहीं है बे विदेशी ला
इसको कॉन्ट्रास्ट
हाँ वही कॉन्ट्रास्ट की ओवेज पागल थोड़ी ना सब करके बनाते हिमालय बन रही है हमारी सब पागल है वहाँ बड़ी ऊपर है ना, तो ठीक है ना, आजा वहीं रखना, वहीं रख, हम ऊपर ही आते हैं।
वो सर शीट को
पीछे ले लो सर, अभी ले लूंगा
क्योंकि वो पीछे वो
लेकिन नहीं ऊपर ये इंटरनल में नहीं है, ये तो एक्शन में पड़ेगा।
नहीं हमारा ऐसा ना हम वापस
नहीं चाहेंगे, मैं वही कह रहा हूँ बहुत नीचे आ गया। चलो कोई नहीं आ जाएंगे।
ऊपर तो नहीं है सर,
दाई डाल के देख लीजिए, लग रही है इसमें से निकल रही है,
यही है
लग रहा है क्या अंदर है क्या?
अंदर तो लग रहा है,
नहीं इतना मूवमेंट नहीं होना चाहिए, अंदर ही है। अब इसमें से गाइडिंग ले, 6 का गाइडिंग या कुछ दे कैथेटर उसके अंदर डालें, गाइडिंग है एक और दे दे, कोई भी ऑक्स एक भी नहीं होता क्या?
नहीं भाई
यार ऐसे कोई तो साला रईस लोग हो यार।
गाइडिंग कहाँ पे डाल देते?
इसमें शीट वायर निकालनी पड़ेगी।
तो एक काम कर, नहीं तो एक काम और कर,
अरे गाइडिंग ले लो ना सर,
एन दे देगा?
हाँ दे दो,
रिप्लेस करवा देंगे,
मैं रिप्लेस करवा दूंगा।
अगर दे देगा तो दे दे, मैं तेरे को चाहता हूँ।
नहीं कर तो सामान लिख के दे देना।
इसका एप्रिल का तो देख लियो, 8 दिया था 5 दिया था,
वो देखने में ही है सर।
8 भी दिया हो तो क्या दे
नहीं मतलब वो
अब तो हो गया।
प्लान क्या है?
वायर इधर से लेंगे, सब काम इधर से कर लेना। नहीं जोड़ के
आई मीन सिंगल स्टैंडिंग
वो तू बताएगा यार, फाइनेंस पे है ना, फाइनेंस नहीं है तो आंसर ही दे दिया, तूने आंसर ही दे दिया ना, हाथ देखना मेरा आएगा ऊपर, मतलब मेरे को मत देखना यार।
चल
वो तीन गाइड रखो, बाद में काम आएगा दूसरे केस में।
ओवर फोर
इसी पे
एनजीओ ना,
इसी पे कर दो इसको, जितना दे सकता है इधर दे दे, एक बार के लिए दे दे। सब ने ये निकाल लिया। से वायर पकड़ ले। अरे कुछ नहीं है ना, बाहर ही है, इतना थोड़ी खींचा। इधर देना, यहीं तो है। अरे कैसे? हो गया ना? मैं इसको लेके थोड़ा लास्ट में लॉक कर, मैं वायर खींचाऊंगा लास्ट में आएगा, ठीक लॉक कर बस रहने दो। फ्लैश दे, अब तेरे को एक करना है तो फिर एक कर ले, बिल्कुल थोड़ा सा प्रोजेक्ट करके कर लेंगे। तो बलून माउंटेड होगा फिर एक लेना मैं घटाइयो,
मैं घटा दो और
एक का क्या 100 ले ले, लंबा ले ले, ज्यादा छोटे में मत
बलून है,
कर ले, बहुत
का बलून और 8 का
ये रख, इसको पहले सीधा कर, फ्लश दे, एक फ्लश दे अच्छे से।
कैमरा ऑन कर दे यार,
वहाँ पे कोई नहीं है,
कौन होगा?
सब लोग चले गए क्या?
खाना इतना अच्छा था, नींद आ रही होगी सबको।
सब चलेगा
ऊपर मैं घटाया था बस।
हाँ सर, सर देखो सर, अब शीट भी आ गई।
ऊपर आ, ऊपर
ऊपर सर, फोटो डालते हैं एक बार।
दैट्स योर फॉल्ट, कर लिया प्लास्टिक का वायर खींचो थोड़ा, क्योंकि गाड़ी निकालनी पड़ती है वायर पकड़ के। ठीक है, थोड़ा आपकी तरफ आ जाना दो, बस परफेक्ट है। चलो अब ऐसा है, इसको कर दी लॉक, इसको गीला कर, इसी पे ले जा 6 का तेरा बलून और उस पे स्टैंड, उधर से रन ले लेना, बलून पे बढ़ जाएगा। और तेरे पास स्टैंड है 100 पे, कोई 100 में 800 है ना, बस ठीक है, परफेक्ट।
ये एसी नहीं चलेगा तो
100 पे क्या दिक्कत है तेरे को? लंबा रख ले,
इधर इधर नीचे ना आ जाए तो
कौन सा पोजीशन 10 सेंटीमीटर की आएगी, होती 15 तो कम से कम होती है। तू बात तो ले, फिर देखेंगे 80 डालना है तो तू एक काम कर, बलून से भी गिनती आ जाएगी ना दोस्त।
हाँ हाँ
एक काम कर, आ जाएगा, सुन एक काम कर, दाई ले, उधर से रन ले लेंगे, अभी पिक्चर बना लेंगे तो अपने को एक आइडिया आ जाएगी। तो उधर से ले, मैं इधर से लेता हूँ तो कितना लीजन है उसको थोड़ी आइडिया देंगे, मेरे को भी एक थोड़ा सा दे दे, फिर हिलाना मत, टेबल लॉक कर देंगे। ये दाई तो ये ले, फिर क्या होगा, 80 है तो 80 ले लेंगे, 100 ले लेंगे,
सब बाहर में 30 करो।
रुक जा भाई, रुक जा, एक रन ले रहे थे बता, तू बताना, तू रेडी है? 1 2 ठीक है, तो इतना लंबा आना है। अब इसको लॉक कर दे दोस्त, टेबल पे
लॉक कर दे भाई, ये लॉक कर
नहीं समझ जाएगा 40 के बलून से। अगर मेरे को तो 100 लग रहा है, क्योंकि 80 भी आ सकता है, ये एक्चुअली मैं नहीं एक्चुअली जो रीजन है ना वो ऐसे नहीं समझ आता। ये जनरली तो 8 की नहीं होती, 6 के आसपास होती है, पर इसकी थोड़ी नीचे आती है, तो 80 भी हो जाना चाहिए आइडियली इसके हिसाब से, तो ठीक हो रहा है।
लेकिन अब देखो ऊपर से हाँ ये है, खराब है, एक्सरसाइज करना पड़ेगा,
हेल्प करो यार उसकी। नेगेटिव लगाना पड़ेगा, पीछे वायर छोटा पड़ सकता है। 150 की शाफ्ट वाला है क्या, कि 130 है शाफ्ट? कितनी शाफ्ट है? 130 होती है, 130
आ गई ना, आ तो गई 130
वायर आई।
हाँ बस आई आई,
आ गई क्या?
आ गई,
जम गया। अब हिलाना मत इसको। सुन यार, एक जन पेन से मार्क कर दो दोस्तों, पेन ले लो यार,
पेन से उस पर मार्क कर दे थोड़ा सा,
फिर ना हम खेलते रहेंगे उसके साथ, एक बार सब उसी से कर लेते ना फिर।
मोटा वाला
बस भैया होने वाला, हिलना मत।
हाँ थोड़ा डालना पड़ेगा, रेडी करनी है तुम्हारा,
लेकिन आपसे जो कलर ये ड्रॉ कैसे
अपने किसी को नहीं समझता, इंडस्ट्री किसको समझता है दोस्त। चलो अपन डालते हैं, मार्क करेंगे बैठ पकड़ ले, टाइट है इसमें मार्कर भी है, ये तो अपने लिए दिखते थोड़ी बाहर के लिए ना, वायर टाइट हो, वायर पकड़ो पीछे। हाँ सुन सुन सुन, हाँ थोड़ा ऊपर, अबे नीचे, थोड़ा नीचे, बस ये यहाँ, बस इससे भी नीचे आने, नीचे आने के लिए नीचे जाएगा स्टैंड, थोड़ा ऊपर, बस यहाँ तक स्टैंड, यहाँ कर करेंगे। अभी तो इतना करेंगे, जो मार्कर है उसे थोड़ा ऊपर रखेंगे, ठीक है? मैं डाल रहा हूँ, पकड़ लो टाइट वायर, लाइक अ गिटार, टाइट लाइक अ गिटार, नहीं तो नहीं जाएगा। तो ये देख तेरा 80 ना छोटा पड़ेगा, ये 4 हो गया और फिर 4 देख नीचे आना 100 लेंगे। लो भाई करो यार, चलो बनो दे। नहीं 6 ले रहे हैं, आराम से करना मन, ज्यादा नहीं, 4 बस। जस्ट मेकिंग स्पेस, एक बार स्टैंड रहेगा तो थोड़ा सा 8 से नहीं करेंगे क्योंकि अंदर
प्लेट कर रहा हूँ मैं।
हाँ करना बेटा, कमर में दर्द होगा जी, आराम से अपन, ठीक है। हाँ 4 करना है, उससे ज्यादा नहीं।
4 हो गया।
चलो थोड़ा सा ये सेव करो, थोड़ा सा और नॉट कर देते हैं इसी को, कुछ नहीं होगा यहाँ कर देंगे। और यहाँ
4
6 करते हैं, 6 का ठीक है। नीचे का
चलो पीछे लेना।
हाँ यहाँ करते थे, यहाँ 4 कर दिए, इधर से रन के रेडी है, मतलब से रन नहीं पड़ता। डाई 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 करियो, डाई हो गया 4 पर डाउन है, डाई डाई
वायर पकड़
नहीं, वो पकड़ी हुई है, लॉक है, निकाल ऑल बटी है। चलो बढ़िया है। अब तुम लोग स्टैंड लो, मैं बताता हूँ नहीं चाहिए। लो भाई 800 दे दे, मतलब वो भी 100 स्टैंड और शीट पीछे ले लेंगे, बढ़िया क्योंकि ना गेट में फंस जाएगा। मेरे को एक जन पेन दे देना जो जिसके हाथ में था, तो मैं इसके साथ इसमें पकड़ के उल्टा पकड़ ये अभी कराने का लास्ट वाला। थोड़ा सा प्रोजेक्ट भी रह गया ना भाई, कुछ नहीं है, ठीक है। हल्का सा प्रोजेक्शन ठीक है क्योंकि हॉस्टेल हो गया तो फंस जाएंगे। थोड़ा सा नॉर्थ रख लेते हैं नहीं तो इधर से नहीं। इस टाइम की साथ कितनी भाई? ये पूरी है 140 35 है, पता नहीं 30 होती है सर। नहीं ये तो छोटी है, लाइफस्टाइल है, ये तो छोटी है, लाइफस्टाइल तो छोटा है 80 सेंट। हां ये तो बिलेरी, अब तो सर ये तो डबल लेंथ वायर भी डाल सकते हैं, ये बिलेरी के लिए है। हां बिलेरी वाला है तो वही समझ में नहीं आ गया हमारे। अच्छा खोल दे खोल दिया। हां ले लो, अब टेबल में दिलाना रे, लॉक कर दे। जो ये बड़े वाले डॉट नहीं, जो मैंने डॉट किया ना इधर वहां रखना, एक आधे में ऊपर ही रखें, कोई दिक्कत नहीं। अगर लगेगा तो फिर सेविंग ग्रेस अपन डाल देंगे, वहां पे कर देगा ही कर कुछ हंस रहा है, कभी देखा डबल हंसा। करना क्या है, फिर वो बताओ ये हो गया, वो बोल देगा ठीक हो गया तेरा बॉस। तो तेरा तो बम्बई है ना, तो बम्बई में कौन है? परेश, नहीं जानते परेश, तो देखना फिर तुम बम्बई वाले हो गए। इधर तो लाने कितना हुआ है। अब यहाँ से खत्म करके फिर हमको ले जाना है एसएस कचौरी, तो क्या 2-3 चीज जगह है, तो एक ही करना था, एक ही हो गया ना। चार का गुण निकाला तूने एक में, जानबूझ के रखा तूने ऐसा से मैं उधर से रन भी ले लूंगा जो डिप्लॉय करेगा ना, देखने के लिए सब परफेक्ट है। आराम से
फिर देख लेते हैं।
नहीं रन तो मैं ले लूंगा वहां से, तू इधर आ जा, तू यू भी कंफर्टेबल, मेरे को डाई दे दे और सीने पे कर लेंगे, ये की जरूरत नहीं है, सीने कर दे, प्योर डाई ले ले, मैं उधर चले जाता हूं। सर सेव हो जाता है ये वाला, सीने की भी जरूरत नहीं है, इनका फ्लोर सेव कर देंगे। नहीं जैसे भी नहीं, क्लियर दिखना चाहिए, और सीने की बात नहीं कर रहा मैं, जो मेरा क्लियरिटी है ना, ताकि तू अब डालना शुरू करे, एक्सट्रैक्ट तो धीरे धीरे डालेगा ही ना। हां मैं थोड़ा सा ऊपर दो, ऊपर तो लेना ही पड़ेगा, ऊपर डाल, फुल पैक कर देंगे, कोई इशू नहीं है। आराम से शुरू कर, फिर नीचे आएगा ये 140 वायर है, डिप्लॉय करना, डिप्लॉय करूँ? हाँ हाँ धीरे धीरे कर।
सर एक बार ऑस्टियम चेक कर लो।
नीचे आ गया। अरे ऑस्टियम ठीक है ना, मैंने मार्क किया ना। सुन
अच्छा मार्क किया।
अमन ये जो डॉट है ना,
हाँ ये ऑस्टियम
है। कर दिख रहा, मैंने जो मार्क किया एग्जैक्ट है, थोड़ा इनफैक्ट मैंने अंदर लिया है। ये जो डॉट है ना, इसके ऊपर मत आ। अब जो अरे मैं करता तो तेरे को करना पड़ेगा क्योंकि ये वंचित वाला तू करना कर बस थोड़ा सा करना, ने जो भी करना करना नहीं ले आएंगे, बस रुक जा। अरे बंद क्यों करता है? ऑन है दोनों ऑन है। अबे यार ऐसे कंफ्यूज मत कर, अब करना कर कुछ नहीं है यार, कर ले आएंगे नीचे। बस रुक जा, ले कर अच्छा उसका सीने का वो मस्त बहुत बढ़िया है,
डिप्लॉय हो जाएगा।
होने दे बहुत बढ़िया है। बस मैं इसको थोड़ा नीचे लूंगा, ये क्या मैं बस इससे नीचे थोड़ा नीचे हो जाएगा। ये भाई आ गया ना बाइफरकेशन, रन ले लेता है यहीं रख नीचे बता देना कहाँ से नीचे आ जाएगा। फिर वो क्या सीने के आगे तेरा होकर पीछे ले ले। ये मेरा डॉट है ना, तो तेरा ये जो डॉट है ये इस डॉट पे आना चाहिए मेरे, ये वाला डॉट इस पे आना चाहिए। अरे कैसे पूरी असेंबली दिखा आएगा कैसे पापा भी आएगा। ये अब इतना टक रख के डाल यहाँ से। हाँ तू ही कर, पीछे मत आने देना। धीरे धीरे कर, ये अपने आप बंद हो जाएगा सीने कर भाई। अब ना आगे जाते ना पीछे कर, बहुत बढ़िया डाल रहा है। थोड़ा सा टक देख के डालना, तेरी तरफ खींच के हल्का सा, बस हल्का सा, ज्यादा नहीं, बस इतना ही। इसको देखते रहे, ये जहाँ मैंने मार्क किया हुआ है बस हल्का सा भी जेल हुआ तो भी कुछ नहीं होता। एक दूसरा उधर आए तो एक और ले लो, ठीक है। एक डॉट है बट दैट इज रिक्वायर्ड, ये बंद हो जाएगा। हल्का सा टक देके रख, हल्का सा ये डॉट है ना, थोड़ा सा यहाँ पूरी असेंबली हल्की सी है तो ना खींचा दिए पीछे। तो एक मिनट क्या नोट करना बस हल्का सा खींच रहा है, हो गया। ले अब डाल बस इतना टक रख के डाल। हाँ बस ज्यादा नहीं, हल्का सा, नहीं तो स्ट्रेच हो जाता है, बहुत लंबा हो जाता है, 100 का 150 बन जाता है। हाँ हाँ क्या रहता है, लेजर कट है, बहुत खींचेगा तो फिर आगे बन जाता है। ये ठीक है, मैंने जो डॉट किया आगे जा रहा है तो हल्का सा इंस्पिरेशन है। क्या चलो ठीक है, अरे कुछ नहीं होता, मैं जस्ट बलून इधर शीट है ना, कुछ नहीं होगा नहीं वैसे भी होगा। और इधर से तो बलून करके मार देना ना, ये शीट भी तो पड़ी है बट इट्स गुड इनफ, एक स्ट्रट से कुछ नहीं होता। शीट नहीं और लीजन है, शीट नहीं है, शीट बहुत बाहर है। चलो रन ले लो, वहीं से ले लेना, इधर से लेना, सीने पे उस पे ले लिए, ऐसे पे ले ले या सीने पे ले ले, सीने पे ज्यादा अच्छा दिख रहा साथ में ऊपर। चलो ठीक है, और लगेगा तो उधर से बलून कर सकते हो तुम, स्टार्ट को इधर करना है तो जरूरत नहीं लगेगी, तो इतना नहीं करना। परफेक्ट है, परफेक्ट है। करना है क्या? नहीं जरूर फिर करना है तो इससे कोई 6 वाले से करना है, रिमॉडलिंग कर दो बाकी। नहीं नीचे तो डिजीज है, फिर वो ऊपर तो अच्छा बनाया था, ऊपर तो बनाया ना। अब ये है एक एक करके निकाल लो, गाइडिंग जहाँ पे थोड़ा सा करके मेहनत करनी पड़ेगी ब्रेक के लिए। वो एंटीजी बनाते ना, तुम किसके लिए बनाते हो, बना देना झोल, वो देख के फिर निकालना कॉकटेल, रेडियल कॉकटेल। हाँ ये निकाल दूंगा मैं, एक कर लूँ ऊपर से पकड़ के अंदर को मत कर, इसको स्टैंड निकाल देगा ना, पहले स्टैंड को खींच ले, स्टैंड बाहर कर दे ना, बाहर कर दे, फिर हमारा निकाल लेगा ना बाद में। चल मैं इधर से एक रन दे रहा हूँ। हाँ क्या ले रहा है तो ऊपर से गाड़ी से ले लेते हैं, बढ़िया है हमारे गाइडिंग से ले लेते हैं, ऊपर गाइडिंग गाइडिंग देखिए पड़ता है। एक मिनट ऊपर देखो, ऊपर देखो। हाँ ठीक है ना, बढ़िया। कॉन्ट्रास्ट करना है, ऊपर से अच्छा ले, पे डाई ज्यादा लेके ले, सेंटर करके सांस रुकवा के ले, उसको पर सांस रोकेगा।
नीचे का भी पूरा लेना पड़ेगा,
फुल कॉन्ट्रास्ट नहीं लेना।
बहुत बढ़िया।
दिखा नीचे नीचे कहाँ लेना है तेरा?
नीचे का एक बार पूरा देखते हैं।
पूरा फ्लोरो
फ्लोर लेते हैं। नहीं डाई करना बेटा।
शीट फिर तेरा राइट का ही लेना है ना?
शीट से ले ले, शीट से ले ले।
चालू है ना?
वो तो कोई बड़ी बात नहीं। क्या है? भाई करो पे वो बोल रहे हैं कि कोड दिखाना है अपन को।
क्या?
कोड देखने का मन है, बोले अपन का।
चल रहा है ना?
अब कहाँ से टाइम थोड़ी है?
नहीं, वो टाइम है, वो टाइम है। काटने चलेगा।
अरे गाड़ी के घर पे ले आता मनोहर, ऐसे ट्रेन इधर से भी आती। चलो निकालो भाई फटाफट। सिर्फ ब्रेक के आराम से।
नीचे का फ्लो है ये नहीं क्या?
पहले एक नीचे का रन मैंने,
अच्छा ले
चला पूरा चलाना है अपने को। हाँ से नहीं कर रहा हूँ।
थोड़ा सा इधर देख, पहले एक बार फ्लोरो दिखा दे। फ्लोरो दिखा। चलो
ठीक है।
हाँ, चलो चलो
चला 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 तो
चलाया कि नहीं?
सेव करना था ना,
सेव कर,
कोई बात नहीं।
तो फ्लोरो भी देख सकते हैं ना।
सेने की जरूरत नहीं, फ्लोरो भी ले।
नीचे पूरे चलाना है ना?
पूरा ले जाना फटाफट एक बार, ठीक है?
चला।
मैंने देखा होगा ना। हरी सिंह जी ठीक है? चलो हो गया, बढ़िया हो गया, बहुत ठीक है।
ये तो ऐसे दिखेगा।
इसको तो निकाल दीजिए।
ये बाहर ऐसे दिखेगा पहले। बाहर से तक जाना।
निकाल दीजिए। नहीं होता।
बाहर पकड़ लेना ना। बाहर की वहाँ कंप्रेशन अच्छा देना है भैया। तो ऊपर नहीं गया तुम लोगों ने?
अरे अल्ट्रासाउंड थोड़ी था राजा। कॉकटेल है? क्या क्या है?
ये बंद कर देना उधर से। दो गाइडिंग करना है ना, दो गाइडिंग इंटीग्रल खुले हैं सेपरेट, ठीक है? और एक अपना H1 खुला है और एक T1 खुला है। चार दो बलून, एक बलून करवा दो। दो बलून नीचे डाल देना और एक कितना 2.5
और 640
और एक स्टैंड
ये ऑल फोर का 200
और एक स्टैंड, ठीक है? ये सारा सामान डलवाना है। बाकी शीट
अरे कोई
इनके
है
दो है ना?
कोई?
बंद क्या कर
तुम्हारा पैन निकला? बंद।
नहीं
वहाँ पे कोई